of the National Health Insurance Agency. Directors here present from the agency. All the special advisors to the DG here present. Members of the non-state actors here present. Our development partners. We have WHO that is here and should be here, not only for the endorsement, but for the work that we've done together with him. And I'd like to give a public apology on behalf of all of us to Dr. Francis. He's the only one I'm going to call out for now. He got the invitation late and he has identified with what is happening here today. Please, can we give him a very loud round of applause? Thank you. I'd also like to mention my brother who is consistent, who is always here. I don't know how he does it. He gets the message from Lagos, and before you know it, maybe he has a private jet. He needs to let us know. Dr. Jimmy, my brother, you're welcome. Thank you very much. We are behind time, and when we talk to health financing, I lump it with health security. I think there is no time to waste. So on behalf of the National Health Insurance Authority, in collaboration with Nigeria UHC Forum, for which I am chair, we are doing things that we normally don't do. I can see my sister Ellen from when did you get in? Thank you so much. Can we please give her another round of applause? So we are getting there. Our young, dynamic, and ready to work Director General has, since he assumed office, at a point I told him that we were getting very worried when he was still in Geneva and is still our DG. But he explained yesterday at a meeting why he had to, come in late, not because he doesn't want to do the work, but that detaching himself from where he was to assume office here. And in his usual style, alongside with the coordinating minister, they gave up the dollar and came home to work. Thank you very much. So you have here a cross section of stakeholders, but I'd like to put on record that we have here the newly elected president of the Health Sector Reform Coalition, who is a health systems person himself, and haven't been, I think, the first amongst the director generals for the National Health Insurance Scheme at that point, Dr. Mohamed Lekki. So after various consultations across board, the DG said he has to speak to us because it's a collective responsibility. So the reason we are here today is to listen out to him and also contribute so that we know where we'll be going together and working together. He said he has an open door policy because for him, what is important is how many enrollees he's able to bring to the table, who will be able to deliver not just on demand, but also for care and going straight to the root, even the environment, even the human resources or medication or whatever that changes the conversation from no hope to renewed hope in the health sector. So I welcome all of us here. If you know him, it's not about the formality or the English that we're spoken today. And that's why I was conscripted to anchor this, because I'm chair of UHC. You'll be wondering why I'm here, but we need to get it right. So if we knock on your door for any assignment, for whatever you need to do, then you know that you're doing it for Nigeria. So this anchor is for Nigeria. So we move on quickly And we need now to set, the agenda, not the ones you are seeing here, but truly the conversation. Where do we want to take health insurance in Nigeria? What is new? We have a new document by law that gives us some measure of understanding of what to do. But today, DG will break that down and let us know where he's going within the context of what the coordinating health minister has set out to achieve for Nigerians in the health sector. So I will quickly please ask that some people would give goodwill messages. You have a maximum of 2 minutes to do that so that we can get into the conversation. Today is Friday. We need to break in good time so we can go to thank God for his mercies on us and indeed Nigeria. So we'll quickly have goodwill messages. Okay, yes, oh my God. Please let's recognize and give a round of applause to USAID Local Health System Sustainability Project. They made this possible. And that applause is not enough because a lot of money went into getting us this comfort. Thank you so very much. So we'll have goodwill messages. If I have anyone from the Federal Ministry of Health present here, okay, we'll get back to that. So quickly, I'd like also to ask that the DPG chair here, okay, very good. So when they come, be sure that we put them at the back so we know they came in late, right? I'm now going to quickly call on HSRC Chair, President Dr. Mohammed Lekki. It's a stakeholders meeting. Can we quickly have you for 2 minutes? And let's give him a round of applause as a council.
Good morning, everyone. Thank you for this opportunity for me to make some very quick, remarks. We're very happy to be here representing the Health Sector Reform Coalition of Nigeria, which is the umbrella coalition for NGOs, individuals, organizations, professional associations that are working in the health space in Nigeria. We are famously known for having been very instrumental for the passage of the National Health Act. Can we give a round of applause for Nigeria, please? Famously. So in that spirit, this Reform Coalition will always align itself with good legislation, good policies, and good initiatives. We do not believe in reproachful approach. We believe in collaborative, encouraging, and supportive approach to make sure that the goals having been set by the duty bearers like the NHIS, and those goals are realized in the benefit of the right holders, which we represent. So it is in that spirit that we are here. We look forward to participating with all MDAs, including NHIA, to help them deliver on their mandates. Thank you very much.
Thank you, very encouraging. Quickly, I'd like to call with much love, Ellen Barua, our own, who also is instrumental to ensuring that USAID LHSS project is sponsoring this. Thank you so much.
Good morning, everyone. I'll just stand on existing protocols. I'm very excited to be asked to give comments today, and I'm very excited about being able to support the NHIA in its next steps. I remember the passing of the original act. This updating of the new act I think is an improvement, but implementation has always been our challenge in Nigeria. We have money now, a little bit of money, and now we have to explain how we're spending it. I am really looking forward to seeing us make more progress. Auntie Muji mentioned the word enrollment. Enrollment is really not the end state. It's part of the process to get us where we're going, which is improved health and reduced risk of increased financial protection and reduced risk of out-of-pocket payments and poverty due to poor health or accessing care, which means that it's not just that you're enrolled, it's that you're willing and able to use that service. And that means collaboration. I'm so glad that Dr. Lecky mentioned collaboration, because I think that is one area where we don't give our very best in Nigeria. We don't collaborate as well as we should with our fellow agencies. So I'm really looking forward to a discussion today on more collaboration with the NHIA, from the NHIA at the state level, more collaboration with its sister agencies, because it takes all of us to make this work. Enrollment is not the end goal, it's utilization. That's what helps us get to better health status. I'm very excited to be here, and I'm very honored. LHSS is very honored to be able to partner with the NHIA, and we're really looking forward to supporting you on your journey. So thank you very much.
Thank you very much. Very reassuring. At this point, at the beginning, I was talking about this gentleman who all you need to do is call him with anything that has to do with health, financing, and health security. Dr. Jimmy Arubalowo, I must get it right today, is here, and we'll give him 2 minutes. And he has to tell us how he's able to make Abuja, Lagos, or Lagos, Abuja in such a short notice. Thank you very much, sir.
Thank you, Auntie Moji, for teaching me all the time. The Deputy Senate Committee Chair on Health, DG, and distinguished guests, all other protocols observed. Permit me to say that the health issues is simply in my blood circulation. And that's the secret. Even at the naming ceremony of my granddaughter, I left the naming ceremony and I went for health issues because we just must move. I'm glad and excited that we have a new DG here, a brother and a friend whom we have been partners since 2010, 2011, 2012. We work together and it's dynamic. And I'm not surprised that still moving up and down because it's a global character. And I believe with all the synergy around collaboration, even with our Oga, Dr. Lecky, and Oga Gafar, the captain, we'll get to the destination. Providers are ready. We are the supply side. Thank you, and God bless you.
Thank you very much, as always. We'll round up this goodwill message, but I can't do that. We need the media, not because that is my constituency, but we need Nigerians to know about the new dawn that we have come all gathered here today to listen on to. I'd like to invite the president of the Association of Nigerian Health Correspondents. You have 2 minutes to tell us, are you going to give this the visibility it deserves? Thank you very much. Please, let's welcome him warmly to the microphone.
Good morning, DG. Good morning to everyone here. I'm Joseph Kadri. I'm the president of the Association of Nigerian Health Journalists, the umbrella body for all health reporters. I can pledge one thing, and it is that we are going to give visibility to what is happening in the new NHIA. And the reason for doing that is to ensure that we have more enrollees. And that way, UHC will just be achieved. Thank you very much.
Thank you for that endorsement. I'd like to call now on WHO, and that will be closing it up on the goodwill message. Yes, we need your endorsement. Is it a priority, what we're doing, and all the works? Thank you. Thank you, Dr. Francis.
Good morning, Deputy Committee Chair on Health in the Senate. Good morning, DG, my own brother, Dr. Kelechi Ohiri, the Chair of the State Social Health Insurance Agency CEOs, Dr. Simeon, my sister Ellen, LHSS, Dr. Leki, and Auntie Mabugunje, and others that I'm seeing. I want to thank the DG and his team for putting this together with support from our colleagues, the LHSS and the UHC 2030 team. The WHO is happy to be here, and I bring you greetings from the WHO representative in Nigeria, Dr. Walter Kazadi Mulumbo. And we are glad to say that we've been with the NHIA and partners on this journey from the very first steps that have been taken. A lot of things have happened, but with the transition, we expect that we steer to the destination point. USC is a journey, and financial risk protection is central to achievement of UHC in any country. And for our country, Nigeria, where as at today, out-of-pocket expenditure is still at 76%. That's very unacceptable. We expect that the highest it will get to would be 40%. But consistently over the past 15 years, we've had out-of-pocket expenditure in Nigeria above 75%. And we have, for many states in Nigeria, catastrophic expenditure above 50%. In fact, there are some states that have catastrophic health expenditure. And what that means is that the percentage of the population that fall into poverty, anytime they fall sick, they receive care or they are not even able to receive care. There are some states that have catastrophic expenditure up to 81%. This is not an exaggeration. What it means is that there are a lot of people in Nigeria that are falling into poverty, but there are even many of them who cannot access care and they die. It is not a situation we would like to continue, and I imagine that's one of the reasons we are here today. So we are here with all the partners and the NHIA in this journey, and we hope that our steps that we are going to be taking moving forward will take us to our destination for the health and well-being and economic prosperity of our people in Nigeria. Thank you very much.
Thank you so much. Thank you. I did announce that we would close this session of the agenda, but I've just been informed that somebody that must help us, we must work together, is here and would like to listen to him, because ultimately it's not Abuja, it is about Nigeria. So on your behalf, Deputy Senate Chair on Health, the DG, distinguished ladies and gentlemen, I'd like to invite Dr. Simeon Onyemachi, who is the head of all the State Executive Director of Health Insurance. Thank you. Good to see you. How are you doing?
Good morning, distinguished Senator, the Director General, NHIA, the LHSS Director, WHO, all other protocols duly and respectfully observed. And Timoji, good morning. It's good to be here. I bring you warm greetings from my colleagues who I see around the room. A couple of them are here. As critical stakeholders, we are very proud of what is happening in our time in the country because from the beginning, we played critical roles in what we are about to take a deep dive into. At the point of enactment, all of the public hearings building up to what we have today as that beautiful piece of legislation that revolutionized everything. Precisely the mandatory clause which has been inserted, which has sent all of us to go to work to ensure that every Nigerian, wherever they reside, they are not left behind in terms of ensuring that we give our people access to healthcare that is of sufficient quality to be effective. As critical stakeholders at the state level, every CEO of state social health insurance schemes or contributory health insurance schemes in Nigeria is going this road with NHIA. You can count on us from our last data, which we gathered by end of April 2024, with the push of the Director General. He said something clear to us that I will not have favorites. My best friends will be those who will ramp up the numbers for me. When you say good morning, tell me, DG, I have brought in XYZ numbers into the pool. From the last meeting we had at that time, I know we were at about 8.107 million Nigerians, 107,000 Nigerians enrolled across the states. But today we have about 9.6 million Nigerians registered from 36 states and FCT. DG, I think we are your good friends and we'll continue to be friends. We will actually not drop the ball until UHC is attained. We're happy to be here and I bring you warm greetings from all of us. Thank you so much.
Thank you very much. My sister Ellen did say that we have to be holistic as we get more enrollees, so also create an environment where improved healthcare delivery will be served to Nigerians. We're very lucky with the 10th Assembly at the Senate. The chair on health is a doctor. The deputy is also one. And here we are today. We have him here with us, who is going to give us opening remarks. He came on time, so I'll give him, sir, just bear your heart. We need to hear from you. Please welcome with me distinguished Senator Samaila Kaila, who is the Deputy Chair on Health at the Senate.
The DG, NHIA, our development partners, distinguished ladies and gentlemen, let me also stand on already established protocols. We politicians, when we're given the opportunity to talk, sometimes we ended up over talking. So for that reason, I decided to scribble some sentences to read so that I'll not be misquoted. It is a great privilege to stand before you today at this pivotal strategic engagement meeting organized by the National Health Insurance Authority. The theme in NHIA Act, 2 years after, reflection and future direction, aptly captures the essence of our gathering as we evaluate our progress and chart the course for future health insurance in Nigeria. On May 19th, 2022, A significant transformation occurred in our nation's healthcare landscape with the enactment of NHIA Act. This landmark legislation, which replaced the NHIS Act of 2004, was a decisive step towards addressing the persistent challenges in our health insurance system by making health insurance mandatory for all Nigerians and legal residents and establishing the Vulnerable Group Fund. The NHIA Act has set the stage for more inclusive, efficient, and equitable healthcare system. Over the past years, we have witnessed the NHIA's commendable effort in fulfilling its expanded role as a promoter, integrator, and regulator of all health insurance schemes in Nigeria. These efforts have been crucial in aligning our strategies with goals of achieving universal healthcare coverage, UHC, by 2030. Today, we are not just reflecting on these achievements, but also reaffirming our commitment to the path ahead. The journey towards UHC is undoubtedly challenging, but it is a journey we must undertake with determination and a collaborative spirit. The NHIA has demonstrated exemplary leadership by holding numerous consultative meetings to ensure that our strategies are well coordinated and effectively implemented. These consultations have been instrumental in identifying gaps, sharing insights, and fostering partnerships that are essential for success of our health insurance initiatives. As we gather here today, it is important to acknowledge the significant strides we've made. We have seen improvements in the accessibility and quality of healthcare services, increased awareness about health insurance, and a growing commitment from both the public and private sectors. However, our work is far from complete. We must continue to build on these achievements and address the remaining challenges with renewed vigor and innovative solutions. One of the critical areas we must focus on is the inclusion of the most vulnerable population in our health insurance schemes. The establishment of the Vulnerable Group Fund is a laudable initiative, but we must ensure that its implementation is effective and that it reaches those who need it the most. This requires continuous monitoring, evaluation, and adjustment of our strategies to meet the evolving needs of our population. Furthermore, we must leverage technology and data to enhance our health insurance system. Digital health solutions can improve efficiency, reduce cost, and provide better health outcomes. By embracing innovation, we can ensure that our health insurance system is responsive, adaptable, and capable of meeting the demands of the 21st century. In addition, we must continue to strengthen our partnerships with all stakeholders, including development partners, healthcare providers, health maintenance organizations, civil society organizations, and the community at large. These partnerships are the bedrock of our success, and by working together, we can create a more robust, resilient health system. I would like to take this opportunity to commend the NHIA and all its partners for their unwavering dedication and hard work. Your efforts over the past 2 years have laid a strong foundation for the future of health insurance in Nigeria. Let us continue to build on this foundation, guided by our shared vision of accessible, equitable, and quality healthcare for all Nigerians. As legislators, We pledge our unwavering support for the NHIA as it continues to fulfill its vital mandate. I implore all stakeholders to remain steadfast in our collective goals to embrace innovative solutions that can enhance our health insurance framework and to maintain an unwavering focus on the need of the most vulnerable in our society. Together with our shared commitment and collaborative efforts, we can achieve the vision of universal health coverage and ensure a healthier future for every Nigerian. Thank you very much for your attention.
Thank you. Another round of applause for our people-oriented Deputy Senate Chair. I was just going to ask him that please, in your next constituency job, remember to also bring on enrollees that you will pay for. I'm not sure how far the 15,000 per annum will go for the very poor. While this is reviewed, make it please a constituency thing that you need and be the evangelist at the Senate for us. Thank you. We're moving on quickly, and he was talking about working together with shared vigor to allow the journey of health finance accelerated in Nigeria and using it as a benchmark, I'm sure, for other African countries. I'd like quickly to recognize that we have with us HIMCAN Chair, Dr. Lekki Ushinowa. Did I get that name right? Okay. Oh, thank you so very much. And of course, we have from the Nigeria Governors Forum, very, very important stakeholders. If we are to achieve this, it has to be at the state level. And Hajia Mariam Yahya is representing Governors Forum. Thank you so much for being here. So we need to meet him. Maybe in the course of his consultations, you probably have met, but he's going to make this very public today. It's always a thing of pride. Everyone calls me Auntie Moji, okay? But you are getting great too. But seriously, this is the nucleus. This should be part of the nucleus for which we can have our dreams for an improved healthcare delivery service in Nigeria. So it's with pride that I call on the Director General and the Chief Executive Officer, Dr. Kelechi Ohiari, to speak to us. But sir, before we do that, one thing I need to say about him is continuity. He believes in continuity, and he has done this with pride. Also, on behalf of everyone who had been, particularly directors, the staff of the National Health Insurance Agency, to give a warm welcome to your Director General, our Director, stand up for recognition. These people have done so well. He got a good team. Yes. Thank you. Let the applause continue until I hand over the microphone. So we'll give him some steam. Careful. Please be seated.
Thank you, Auntie Moji. Actually, the gray hair has tripled since I started this job. Distinguished Senator, Vice Chair of the Senate Committee on Health, you're welcome. Heads of agencies and other development partners, HIMCAN presidents, the chair of the state health insurance schemes, representative of the Nigerian Governors Forum, the Director, LHSS, Dr. Elaine Barua, who I've known for many years. And I'll stand on all the existing protocol and just say, good morning and welcome. And thank you for being here today. The notice was short, and I think it's characteristic of the blistering pace that things have been unfolding in the health insurance landscape. Yesterday in a meeting, I likened it to what happened during COVID, where every Nigerian became an epidemiologist and they knew everything that was going on. They knew about case fatality, they knew about prevalence, incidence, etc. We've come to a point where if you listen to the news, almost every Nigerian is becoming a health economist and a health insurance expert these days. In different climes, that would have been music to our ears, right? Because sometimes our work tends to be so technical, it is hard to actually get people on board. But this time, it's resonating with many people, not necessarily because we have successfully convinced them on the importance of health insurance, but sometimes because their first encounter with the concept tends to be where there is more to be desired in the way the system works for them. But nonetheless, we shall not waste that opportunity to continue to educate Nigerians and continue to create awareness. So today, when I took this job and finally extricated myself from my previous role, I made it a point to not make any assumptions. And at the first meeting I had with my top management team, I said I was here to listen, to learn, and to better understand the system. And I have been listening, and I will still continue to listen. Learning, of course, is a lifelong thing, so we'll continue to learn. The understanding part, I think that's also a lifelong journey. But I think we've come to a point where it's time for us to begin to translate the collective wisdom that we've garnered, the collective knowledge that you have been generous to us in sharing, into an articulated path forward where we'll begin to address some of the things. In one meeting with the medical directors of the National Obstetric Fistula Centers, there was a particular story that haunted me for 3 days straight. And as you're aware, one of the priorities of the Coordinating Minister of Health and Social Welfare is to crash maternal mortality, where as part of the sector-wide program, we're all looking at what role we can play, and as the NHIA, how we can be an effective strategic purchaser. And of course, when someone comes to an emergency room, that's not the time to start preaching about coverage. You want to address the index problem and then afford them or accord them the financial protection they need prospectively. So one of the vulnerable groups, or the expansion of the definition of vulnerability, was to include women who were at risk of maternal mortality, but also significant morbidity like obstetric fistula. I think nothing typifies the health sector renewal investment initiative objective of reducing physical, financial, and emotional pain than women who suffer from obstetric fistula. They tend to be extremely poor. They're usually malnourished and anemic. As a result of the issue they face, they are usually ostracized from society. And what could have been an acutely addressed issue often becomes a chronic problem. And so when they were narrating their experiences, they mentioned the case of a woman who was saving money, but could only save about 3,000 naira every year in order to travel across state lines to one of the centers. And she had to save for quite a few years before she could afford care. Now just imagine what that woman will be going through. Something that could easily be resolved. That is the center of what we're supposed to be doing. That is what enhancing financial access to care would be. And as Elaine put it, it's not just saying coverage, it's also utilization. And for that woman, it's getting to that point where that issue is resolved. And that's reminded me and was sort of something that kept on sticking in my mind as to this thing that we are doing, this journey doesn't mean anything if at the end of the day, people like that woman cannot access the care that they need. And that's where the role of the NHIA and our goal of enhancing financial access becomes quite important. So today, I will focus my conversation on 4 things. One is just a reflection. It's been 2 years since the NHIA Act was signed into law. It was actually May 2022. And so it means that it's an opportune moment for us to reflect, look at the journey we have come to so far. Some of the architects and the pioneers like Dr. Lekki are here, on whose shoulders we build on. Secondly, we look at what we have accomplished collectively. And this is not speaking to just the NHIA or what it used to be known as the NHIS. This is a collective mandate. It's not all bad. A lot has been done. And we should reflect on some of them. But also, we've had challenges. And we're at a point where we're at an inflection point. We should examine, why do we have these challenges? What are the root causes? And then hopefully begin to chart a path towards addressing them. Humbly recognizing our role, the NHIA, as the entity that is responsible for promoting insurance as an effective means of financial protection, for regulating the industry so that as a whole, the industry begins to perform as it should to ensure coverage for all Nigerians. And then thirdly, to integrate what many might think is an extremely fragmented system. So we'll lay out a vision and path, and then we will have panel sessions where we'll also hear from other experts today. And then hopefully we'll get a chance to bring it all together towards the end. Next slide, please. So just down, memory lane. 1999 was when the NHIS was established. Some people, everybody here was born by then, right? And the objectives were very clear. It was to ensure that every Nigerian had access to good health care. It was to protect families from financial hardship. It was to limit the rise of the cost of health services through effectively managing what it will take to treat people, etc., etc. I'm not going to read everything. But it had extremely good initiatives. And the interesting thing about health insurance in Nigeria was that even before the health insurance scheme was set up, we already had an active private sector that was driving or trying to introduce the concept of health insurance. But since its creation, next slide, please, it has changed and evolved. In 1999, an Act 35, set it up. By 2004, the NHIS Act was introduced, and with that came the concept of national health insurance for Nigerians. By 2005, it was officially launched on the 6th of June and began services to enrollees. By 2010, it began to recognize the need for mandating subsectors of our population to be covered. So federal government employees became enrolled mandatorily in 2010. By 2014, due to a lot of advocacy by critical partners in the room, including Dr. Lecky, some members of the UHC Forum, the National Health Act was signed into law, and with that came the Basic Healthcare Provision Fund, where the government of Nigeria intentionally and deliberately began to address some of the equity issues in insurance coverage. So with that was 1% of the consolidated revenue. 50% of that goes to the NHIS, or went to NHIS, and now NHIA Gateway. And with our partners in the States, we implement that. That was further strengthened in 2022 when the NHIA Act was signed into law, and that repealed the NHIS Act of 2024 and established the NHIA. That shift had some consequences, and I'll just highlight 6 of them. One was the establishment of NHIA as an authority and not just a scheme that's been run. The second was the elucidation of the function of the NHIA to promote, regulate, integrate and regulate all health insurance schemes in Nigeria, public and private. A third was the establishment of state health insurance or state contributory health schemes. Some had already been in place, but I think this was a law that actually put them and enshrined them within the context of the Health Insurance Act. And as Dr. Simeon mentioned, we've seen how important that contribution and that singular action has been. A pivotal part that was mentioned, Section 14 of the Act, which mentioned that participation in health insurance be made mandatory for all Nigerians and legal residents in the country. Up until then, it had been voluntary. So most times when I'm asked, why has health insurance coverage been low for the past 20 years? Well, it's been voluntary. And if we know anything about market failures in healthcare, we know that there's no incentive for people who are well to take up insurance. Many countries struggle with that, except some form of mandate is put in place. That's why even in the US with the Affordable Care Act, it was made mandatory. Challenged later on, but the principle is still the same. Section 24 elaborated on the implementation of the Basic Healthcare Provision Fund, and Section 25 talked about the Vulnerable Group Fund, all geared again towards seeing how we can move health insurance away from just the formal sector and the organized private sector to looking at a way to expand this to Nigerians. But as been mentioned before, even though this was done 2 years ago, does it suffice? Are we where we should be? 2 years of implementing? Not yet. But one thing to state is that we have made a lot of progress. Operation, yes, the transformation and the development of the operational guidelines by my predecessor, Professor Sambo, and some of the leadership of the NHIA. And that began to articulate what does this new act mean for us as an industry in terms of the way we operate. Recognize that most of that has started kicking off, but there's a significant part of the operational guidelines that need to be put into place. But programmatically as well, the Vulnerable Group Fund was established and appropriation was made this year in the budget. And for the first time, we know that there is room for more, but I think let's even start with showing what we can demonstrate with what we have. I'm happy to also say that all 36 states in the country and the FCT now have state health insurance schemes. This wasn't the case before, but As at last month, every state in the country now had one. We know that the NHIA has taken on its role as a regulator, but also an enforcer much more seriously in terms of trying to mediate and address complaints that come out in the system. This is still work in progress, but kudos to the team who have been hard at this, such that in a year, about 3,000 incidences were handled and about 90% of them resolved. We know that the numbers of lives covered through the BHCPF has increased. We have roughly 2 million lives covered. So these are 2 million people who, without this intervention, would not have had any access to coverage. We also know that for the formal sector, about almost all MDAs have some form of insurance where their enrollees, where their staff are covered. But we know that there's still a gap, right? So even though we recognize that the non-contributory schemes have grown significantly, we have roughly 3.5 or 3.7 million of such over the years. So the orange line there represents state government equity funds, and then the green line represents the BHCPF. So we've seen substantial growth. And just to buttress my point that since the states came on board, we've seen significant contribution from them. Next slide. We've also seen that the contributory schemes have grown substantially. And for us to close the gap for universal healthcare coverage, we know we have to work on both mobilizing additional fiscal space by the government and by other well-meaning Nigerians, development partners who want to pull into the Vulnerable Group Fund. But also, let's not forget that we also need to harness the contributory portion, which is those who can pay. They are paying, but they are paying out of pockets at the time they need. We know the recent estimates that was provided by the Presidential Committee on Unlocking the Healthcare Value Chain put the number at $2 billion in the equivalent of what Nigerians spend outside Nigeria every year through outbound medical tourism. These are monies that could be spent within the system, but even better, some of it could have been pulled into a prepayment mechanism that insurance offers people. We have the challenge of the informal sector, but these are things we will definitely overcome in the years to come. We've made some progress, but as mentioned, 4 major challenges persist. Low coverage being one that I am quite exercised by. And this is because not only is it unfair for a lot of Nigerians to have to pay out of pocket, so just from a moral perspective, what most of us in this room enjoy is just that peace of mind to know that if you're sick, you can show up. And you're not really worried about whether it's going to cost you 100,000 naira or 500,000 naira, and you have to have that money in your account at that moment. But just think psychologically for those who don't. I mean, one of the panels I was on recently, the person representing the HMO said their biggest competitor was, it's not my portion. And of course, it's easy to think it's a technical problem, just more awareness. But just imagine, why do Nigerians say it's not my portion? They say it's not my portion because if they ever have to have a major health incident, what would ensue in the pain, the desperation, the financial implications, the potential impoverishment? Nobody wishes it for themselves. So they just say, it's not my portion. So with health insurance, with education, with awareness, with trust, etc., we can begin to change that narrative. Uneven distribution of coverage, we've talked about, and underdeveloped markets. Nigeria is one of those rare countries that has a mixed healthcare system, both on the provider side and on the payer side. I'll come to that in a second when I'm charting a way forward, but just understand this. many of the countries that Nigeria is benchmarked against, let's say our brothers in Ghana or Rwanda, tend to have one thing in common. It's one risk pool. It's one health insurance program. So when I try to explain the Nigerian health insurance landscape, people look at me like, oh, did you mean something else? And I tell them, actually, we have a national health scheme. We have 37 state schemes, and we have 80 HMOs. And they start doing the math. Like, yeah, it's about 130 roughly. And they don't understand why is it so complex. But then, well, there's a political economy to this. Nigeria is one of the most fiscally devolved countries around. And every system has to design its program based on the peculiarities of that system. So, but what we have to do as an integrator is how do we harness the advantages of having this? How do we reduce the fragmentation of the risk pools that we have? How do we deal with the variability in competency levels as such that come in the industry? So that's a critical challenge that we face. And then the issue of quality of care. So suboptimal quality of care, partly driven by issues around the tariffs, or partly driven by lack of clarity. What is the minimum benefit package? You find innovative people saying, we have a health insurance coverage for malaria and typhoid. We have one for just full blood counts. We have another one that'll cover XYZ. Creates confusion. There's way too much fragmentation. It affects quality of care. It affects patient experience. It affects enrollee satisfaction. It damages the credibility of insurance as a tool for financial protection. There are many challenges, but these are just some of the more fundamental ones that we have highlighted. When you look at the breakdown of how many Nigerians are covered by different, population segments. Okay, of the total population of roughly 220, roughly 60 million people are covered. But with Dr. Simeon's new numbers, that will be updated. When you break it down and look at those in the public sector and the large private sector, it's 62% of them covered. So it tells you who are those that are benefiting from insurance. When you look at the informal sector, where most Nigerians are, it's just 1% that is covered. When you look at those who have worked and toiled and supported our country and have retired, that number is even smaller, it's 0.04%. And then, of course, if you look at those who are unemployed, those who are out of the labor force, it's an impressive 9% only because of some of the government subsidies through BHCPF and VGF that are going on. So what does this story tell us? It tells us that the majority of Nigerians are not covered, but more so, what we enjoy as those that work in the formal sector, the rest of the country still lacks that. And where the opportunities exist are in those segments, because very soon we'll max out on the formal sector and the large private sector. And so growth of the industry will largely be determined by to what extent we are able to actually address this issue of fiscal space, but also address the issue of the informal sector. This is a breakdown by different schemes and different plans. The NHIA, through the program it runs, the state health insurance agencies, BHCPF, what is covered by the defense HMO, we call that out because it was quite large and sizable, and the private health insurance schemes, what they cover. So first 4 public schemes, the last 1 private schemes, just to give you a sense of the numbers there. So that was the picture. Now, where are we? To begin to switch towards looking forward. We know that this is very important to His Excellency, Mr. President, and his agenda, the Renewed Hope agenda. In fact, certain quotes attributed to him. were that our healthcare reforms and policy shall be defined by the concept of universal healthcare coverage. And our healthcare delivery strategy will target the poor and marginalized communities, leaving no one behind. And therefore will frontally address our nation's healthcare challenges, including poor insurance coverage, high maternal and infant mortality, inadequate preventive care. And these are policy statements that show the level of importance that is accorded to what we do. And this has been reinforced in subsequent interactions with him. So a lot of the president's vision has been captured in the next slide, which is the Health Sector Renewal Investment Initiative that many of us are familiar with and socialized. Now we looked at this, and within this we derived as the NHIA, how do we contribute to this broader agenda? And the areas in green highlight some of those critical elements in effective governance, in facilitating access to equitable and quality health systems, unlocking the healthcare value chain, which is how do we work with the private sector to actually improve access to care. The enablers are similar to ours. So this is the minister's agenda, and this is how what we do fits into that broader agenda in the principle of a sector-wide approach to achieving these objectives. So in our journey to define what we did, I think it's important to recognize a lot of the stakeholders that we've engaged with, because whatever we've come up with is our collective wisdom and attempt to distill those. So we've had workshops and meetings with health maintenance organizations in February. And Dr. Leke and his colleagues graced us with their presence. I think we had almost 100 chief executives there that day. And we spent the whole day with them, including breakout sessions and everything. It's a testament to their level of commitment and engagement. The coordinating minister was there as well. The chair of the state's health insurance schemes was also there. So that was sort of one of the pivotal meetings that we had. We've also had several one-on-one meetings and interviews. We've had meetings with them to try to begin to brainstorm some of the fundamental challenges the private is facing in the insurance space. We've also met with our comrades in arms, the state health insurance agencies, with multiple workshops and meetings, and consistently work together with them. We've had meetings with provider associations, including yesterday. We've had with Guild of Medical Directors, Association of Private Medical Providers of Nigeria, also with HCPAN as well. And then we've also had meetings with NHIA management staff, just focusing on trying to articulate this. And last but not the least, we finally had the privilege of welcoming some representatives of civil society organizations to our office yesterday, led by Antimoji herself and Dr. Gafar, who graced us with their presence yesterday. So these were just some of the engagements, in addition to a lot of one-on-one meetings and councils. So when we bring all this together, what is the plan, really? What are we really trying to do going forward? Of course, our goal is to bring millions of Nigerians out of health poverty. Health poverty. And that can be construed in two ways, and both are relevant. One, it means that for those who do not have money, are poor, and therefore cannot access healthcare as a result, you want to target them. It also means those who actually might have some money, actually have a pocket, but are just one catastrophic illness away from being plunged back into poverty because they pay out of pocket. You also want to target them. So you want to bring people out of perennial health poverty. You want to prevent people from falling into poverty as a result of ill health. And we try to do this by enhancing financial access using insurance as a mechanism. And so what's our objective as the NHIA? Of course, drawing from the strategic plan that we have, which is currently being revised, given that we have moved from being a scheme to an authority. 4 things. And I call them the coverage goal, the equity goal, the quality goal, and the efficiency goal. So coverage, of course, this has been my fundamental obsession, because if more people are not covered, then what are we really doing? And so that coverage means people need to get covered. But how do we want to cover people? I think there are 3 things that we need to get right. 1, the Act has already given us a mandate to make sure we enforce the mandatory nature of health insurance and actually ensure that people are compliant with it. So this involves NHIA, going ahead, taking those guidelines, secularizing them, and working with partners within the health sector, but also outside that can help us actually enforce this, because we can't do it alone. And I think, speaking to that principle of collaboration that Dr. Lecky mentioned, it has to take a collaborative effort. The second thing is not just enough to mandate people. People need to be aware. We need to get more people to understand what health insurance means. And then thirdly, trust needs to be rebuilt. If you're insured, it has to mean something. Fundamentally, it should mean at least that when you're ill, but you're insured, you should have that confidence that when you go to a facility, 1, there'll be a qualified provider that will attend to you. It also means that you don't have to be plunged into poverty because you're paying a lot of money out of pocket. If you can't assure people of those 2 basic things, then there becomes a trust deficit, and it becomes harder to convince people as to why they should want to get health insurance. If insurance were a product, there needs to be a product market fit, right? You can't sell a faulty product. So we need to make sure that there is trust in what we're doing. The equity goal is a path that Nigeria has started on, but we need to progressively realize. And it's really focusing on what the NHI wants to do, is to make sure that we effectively operationalize the Basic Healthcare Provision Fund, and we begin to use the Vulnerable Group Fund to begin to expand that definition of vulnerability to actually ensure that it achieves the purpose for what it was set up. And that Vulnerable Group Fund opens us up to multiple sources of funding and revenue, including fiscal policy innovations that we need to do, as well as other things, whether it's taxes, etc. But that has to cover the poor, those 80-something million Nigerians who live in multidimensional poverty that can't contribute. Quality, we've talked about it, which is 2 things really. 1 is we need to set the standards, and not just standards in terms of quality of care by our providers, but standards in terms of what does insurance mean? What should people pay for it? And that's why one of the things that we've already started on that was the actuarial work to really review existing tariffs, looking at the benefit package, the risk pools we have, and using that as a foundation to begin to set the standard for what is expected. We need to define a mandatory minimum. Of course, people are more than welcome. Every scheme is more than welcome to offer additional levels of coverage for multiple things. But the responsibility to define the base, what is insurance in Nigeria? Because when you say you want to enforce compliance, compliance with what? I once went to a place, I shall not mention the name, and I asked one of the workers there, so when you're sick, are you covered? Do you have insurance? And the answer was, well, it depends. Like in Nigeria, everything depends, right? I said, depends on what? I said, well, first it depends on the level you're in the organization. Okay, I said, at your level. He said, well, if he falls sick at work, he's covered. But if he falls sick at home, he's not covered. Please, is that insurance? But if you probably ask that institution, They'll say we provide healthcare coverage for all our staff. What is the mandatory minimum? That is the role of the regulatory agency. And that's something we have to take seriously in defining it. And then, of course, if you want, to have additional coverage, additional things, then that is fine. But we need to align on that. Improving market efficiency, I've touched on that. We have a very fragmented system. Now, what that happens if we tell ourselves the truth? There will be HMOs that have 100 lives. And just from a risk perspective, how are you surviving? If 50 of you have malaria, what will happen? Insurance functions on the basis of risk pooling. And so we have to look at what will it take to incentivize the private sector so that they begin to see that the way they should pursue growth and profitability is through volume, expanding access to more people, because that is the point at which we are all aligned on universal health coverage. But if it is profiteering and just profit maximizing, you take, you steal my enrollee today, next year I steal your enrollee, then that's a low-level equilibrium. And the third question is, what do we do as promoters to shape that market effectively? What are the constraints and the challenges they are facing? Is it access to capital? Is it just creating a proper regulatory framework for them to operate? For the public sector, we find the same thing. Different state health insurance schemes at different levels. Issues around portability. I work in Abuja. I live in Nasarawa State. Where do I buy insurance? If I buy insurance in Nasarawa and show up in Abuja, and something happens to me, I have food poisoning, I go to the hospital. The hospital in Abuja needs to be sure that Nasarawa State Health Insurance Entity is going to honor their claims. And all this comes by standardizing what it is when you say people are insured. It also means that for the state health insurance schemes, we need to look at a way that we can help them and build their capacity from where they are through a maturity model to where they should be, looking at everything from targeting beneficiaries to managing claims to managing risk and also the reinsurance function. So we've had several conversations together and brainstormed with the state health insurance schemes. We've also had that privilege to work with the HMOs to see how do we make this market work for all Nigerians? Because that's what the Nigerian cares about is still back to that whole, if I'm covered and I show up, do I get care? And I don't have to, sell everything I have to afford it. Quickly, 3 enablers for that. Because we also have to focus on ourselves as an institution. What does that transformation from being a scheme to an institution mean? One is citizen-centered engagement. And this is where I have spoken to the CSOs that in addition to what we do as the NHIA, to try to get feedback. I do a lot of mystery shopping, shop at enrollment centers, ask people, why are you even being insured? Who told you about this, etc. But we also need independent feedback and accountability, because the unit of intervention in insurance is the enrollee. It's not the facility. It's not any other thing that is esoteric in our system. It has to be about that enrollee. So making sure we prioritize, and then enrollees exist. They are human beings, and they should have an NIN number. So we should depart from where we enroll people and we're wondering, is it really 50? We're not sure. Let's go and verify. So aligning with what government policy is concerning national identity. And so that's where we're moving, where NIN becomes the evidence that you actually have insurance coverage. Maybe that might result in our numbers dropping a bit. That's fine, but let's understand what we're actually working with. Data and technology, I think there's no need to say more on that. And then lastly is our own organization as the NHIA. We're currently looking inward. How do we need to restructure ourselves? How do we need to strengthen our financial management systems? How do we need to look at our organizational design to see if it's fit for purpose for what we're trying to do? And some of those conversations have started and will continue all through this year and going on, because that strategic shift is needed. So what are we on the hook for? So there was a presidential commitment that was signed by the minister, and I'm supposed to be there right now because I think the minister is having his 1 year scorecard conversation this morning. So to achieve a 20% growth. But I'm sure all of us know that we can do better than that. Is there anyone who, if you think we can do better, please just raise your hand. Let me know if I should just, okay. If you don't think we can, no. So I think we're in alignment that we can exceed this goal. And so this should be at least the list of what we should attain. And we also know that, you know, during, I believe, the political campaign seasons, numbers around 40 million were circulating, right? But you know, as they say, we campaign in poetry, but we govern in prose. So in this case, there's an aspiration to get to 30 to 40 million people. But that's not going to come by incremental approaches to it. Some major shifts have to occur for us to get there. But just to let you know that this is not NHIA DG's target. This is our collective target and responsibility. But for this to happen, so a few things, there are success factors, just to highlight a few. Well, we know that private sector participation is critical. Opportunities exist in the informal sector for the contributory parts of that scheme. We know that for that to happen, some of the private health insurance agents from the industry analysis we've done will need to access the requisite capital and balance sheet to actually drive enrollment. We know that we need to innovate on things, on fiscal space, on how we can make it easier for people to enroll. In countries that have very solid social security systems, there are ways you can actually access those funds. But in an informal sector, it requires us really thinking innovatively as to what we can do. We know that government revenue and government's revenue allocated to healthcare needs to increase, particularly that allocated to health insurance. If only 1% of people are covered in the informal sector, only 9% of those who are poor and unemployed are covered, can we raise that? And that comes from pulling resources much more centrally. We can't depend on contributions alone for that. So there's a non-contributory part where government resources have to come into play. And of course, where there are donor contributions and other sources as articulated by the VGF, that would make sense. And then, of course, our subnational counterparts at the state and local government levels can do a lot. As Dr. Simeon has shown and demonstrated, by the time formal sector workers in all the states become part of it, by the time more states establish equity funds, that should just be the baseline. And by the time more states start targeting their informal sectors and moving to actually cover other people, those numbers will increase. So you see, it's not, one thing that is resonating here is the fact that it's a collective effort that is needed for us to achieve this. So I think just wrapping up is to say we all have a role to play. Just highlighting a couple here. For us as NHIA, we're committed to the openness, to consistent dialogue, to taking the mantle that has been given to us by the NHIA Act of 2022 to do more, to set standards, to enforce compliance, to work with critical partners, to regulate, to help integrate a system under health insurance under one roof so as to reduce fragmentation. We will do that. From the different stakeholders, from the HMOs, I encourage you to continue to drive enrollment, encourage you to also go after those in the informal sectors, for all of us collectively to be more transparent in data, for the state health insurance agencies, we'll continue to work with you to build capability and to see how we can properly manage risk pools. For the healthcare providers, you are the point of engagement. Everything we do translates into when that person shows up, when that service utilization point occurs. It's that experience with you that determines the perception of the entire industry. For the development partners who have been supportive, working with us, please feel free to participate in the VGF. Continue the partnership, thought leadership, and technical support you're providing. Continue to collaborate with us as we navigate what is a very complex health insurance landscape. And for civil society, step up the advocacy, continue to work with us to increase awareness of health insurance, but also please hold us accountable all the time. And so you see that if there's any message to come to land this, is to say, one, it's a collective responsibility for all of us, and we'll have a role to play. It's that the NHIA will continue to be open to dialogue and engagement. We've already set up like quarterly standing meetings with some of the different stakeholder groups. It's also that whereas every single aspect of it is important, we need to enroll more people for insurance to work. And so we should also hold ourselves accountable towards enrollment, which is my obsession. But I would also say,
she by herself got the tell later.
Enrolled has to translate into access, utilization, good quality, and a reduction in out-of-pocket expenditure. So with that, I'll just say thank you. We have thrown out our views. We try to keep it shorter. We try to reduce it. I try to say, no, as a former management consultant in a different part, it shouldn't be more than 3. But the level of complexity we face is that everything is interlinked. You need to address them. And I didn't want to cheat and just merge equity with coverage and say it's coverage and equity and all that. But these are the things that are derived from the key issues that we face in the industry. So with that, I hope, reflecting on 2 years after it was a great step in the right direction for Nigeria. We haven't optimized and reached the potential of where it should be. We're at an inflection point now where internally we have an NHIA that is ready to reform itself in order to meet up and rise up to that challenge. We have Nigerians who are asking questions of us, who are asking every day about insurance. Everybody's a health economist. Everybody's an insurance expert now. But more importantly, we also have stakeholders who are passionate about it. And I hope that over the next few years, that this becomes a turning point and we can rise up to the challenge before us and to the opportunity that I see in this sector. And we can ensure that on our march to UHC, next time we come back, we won't be talking about single-digit coverage. Next time we come around, we will actually see ourselves progressing towards achieving universal health coverage and collectively exceed the 20% improvements in coverage that has been set before us and actually see significant progress. So thank you very much. I know I've spoken for a long time. I just wanted to make sure it was clear.
Madam Joy,
please, for all the hard questions, my staff are here, so you can ask them. Dr. Gafar, Francis, different people are here to take all the difficult questions. Well, thank you very much, Auntie Moji.
Say nothing serious. infection dey her body for over 2 years. Is there something now? But na the sexual complaint infection abi.
Well,
All
thank you very
get
much.
am.
I had a little
And we don't just want to tell you.
insight into
Right
that
now, she dey on
presentation
strong
24
antibiotics.
hours ago.
Right
And
now,
I'm
when I
still
said
very, very, very
the
excited.
test don't come out.
A
Staphylococcus
couple of
aureus.
things has to
How much
happen
will you- That
quickly.
is, you know, I know they come out.
You know that ministers
But the
are given an account,
look that
like a
join wetin dey each
scorecard
house.
going on currently.
So as you
And
start,
in a
as
few
her sugar
moments,
drop, teaching,
it will be the turn of the health
those
sector.
already under her breast, all
So
those ones
the
try.
DG would leave us. We'll have tea, coffee.
The
Hopefully
vaginal
he'll be back
discharge too
then.
reduce.
Please, and I saw
Like,
a lot of
according to
people
her,
writing
teaching just
copiously.
stop.
I'm
Even
sure
for
your
her face, you will
questions
see say she
are
just
there,
dey vex.
or things that we can
Even before she
integrate
start the medication,
what he has
maybe
delivered.
I start her
So
diet.
please put those questions aside for now. And when he comes back,
No,
we'll
say,
have the
what did they
interactive session. But we're going to take pictures now. I need the photographers to advise me. Maybe we'll take it in, we have to take it in sessions, right? Yes. So DG and our Deputy Chair Senate, please, can you please come up this table? Can we have this table? Dr. Lecky, can you join this? And all our development partners. Yes, sir. Yes, I think some people will be down here and some others who are as tall as I am would have to go up. Yes. Yes. Dr. Jimmy, please come on and join. Health Commissioner's lead is here from Nasarawa State. We welcome you. Let's see how many. Yeah, okay. Nigerian UAC Forum. Yes. Okay, please, some people can go at the back there and just climb on the stair, well, on the platform. Yes. Dr. Mabogunje, please. Dr. Mabogunje, Lola, please, can you join us here? Who again have I left behind for this? I'm sure no one. Are we okay here? Are you as tall as I am? Oh. Yes. Next will be, please, sir, can you both just remain? So now have this. Have this table and all the directors here. NHI directors. This table and NHI directors. NHI directors. Yes, one more, please. One more. One more set. Okay. We thank you very much. I think coffee is served out there. Please, let's go for coffee. Yes. Also for the media representatives here, when the DG comes back, we would arrange for you to meet with him and get some interviews done. Coffee is served. Please, let's go out for coffee. Hi. How are you? Oh. Yeah, I don't want that. Okay. Okay.
No, I got different departments, but yeah, majorly though.
Now the oga dey actually dey chop the money sha, not be the downstairs. Directors.
The down staff too go dey chop. We need to season yìí à ń wá owó gan. A ní láti tá a bá ti sort it out. Màá look into kíní ẹ̀. Mi kò lè I just hope it's quick. A dẹ̀ ń gba àwọn marketers bíi mẹ́rin kan. Èmi gan for us láti gba marketer mo ní láti drop salary because a lè afford it but we need it. I gats tell them make they reduce my own salary so that we'll fit pay new staff. So èmi gan salary mi gan ti lọlẹ̀.
Now mute yourself. People are hearing what you're saying, no.
Hold on, sit down.
Please, can we all come in and get settled for the next agenda? May I please plead that you come, if you have not had your coffee, you can walk in with your coffee, can bring your coffee in. Yes, tea time is over. Tea time is over. Can we please all go in? Hi. Thank you. Tea time is over. Can we? All right. Yes, can we settle down? Thank you. Thank you. Morning. We need to respect time. You know, today is Jumat, and some of us would leave for prayers at the appropriate time. Yes, okay. Thank you very much. I hope oh my God, our virtual participants, thank you for staying on. I wish I could have sent you ET break, but technology has not been able to get that done. So we're on to the very important next item, which is going to be speaking to fiscal space analysis for the Vulnerable Group Forum. Can we please have the front door shut so we can start? So our next presenter is one who is, if she had the power, she would want health financing to be a thing of just going to your facility, being able to access health when you need it. Dr. Bola Olushola Faleye is our next presenter. She's the country lead for the USAID Local Health System Sustainability Project. Outside coming to share her passion with us, she also ensured that we have this comfortable space for us to speak to the importance of health financing. Please, let's welcome her very, very warmly. That's not good enough for your sponsor. If she takes her purse away now, the Continental Hotel will ask us to leave. So thank you very much. Thank you for all you do.
The DG NHIA, Dr. Kolechi Ohiri, and the entire NHIA team, the chair of the SHARE CEOs, Dr. Simeon Oyemechi, a very dear good friend, and of course, the entire SHARE body of the SHARE CEOs and members of staff here present, my boss, the LHSS Regional Director, Dr. Elaine Barua, colleagues and friends, please allow me to stand on the protocol so already solidly established by Auntie Moji. Today is an honor to share the findings from the fiscal space analysis we conducted to determine the financing options for the Vulnerable Group Fund. These findings have already benefited from an initial review by the NHIA DG and by my boss, Dr. Elaine Barua, who have contributed so much to improving the quality of what we first presented during the Universal Health Coverage Day celebrations in December. We thank them for their contributions. By way of introduction, we know that the Vulnerable Group Fund was first introduced by the NHIA Act of 2022 to provide health coverage for 83 million poor and vulnerable Nigerians, and that the VGF fulfills one of the two criteria for universality of health insurance coverage, that is mandatory participation and subsidizing premium for the poor. And of course, it is justified by the increasing out-of-pocket expenditure in Nigeria above acceptable levels at about 75% household health expenditure on health. We know that the VGF also features prominently in the Nigerian Health Sector Renewal Investment Program, is a major part of the Coordinating Minister's new blueprint for health, alongside community-based service delivery, direct facility financing, secondary care, and of course, medical and public health emergency funds. We know it has the potential to resolve the disparities that currently exist between the poor and the rich in our country. We know, as a matter of fact, that women that belong to the higher socioeconomic group are 10 times more likely to have access to skilled birth attendants compared to women from the lower socioeconomic groups. We know that children from the lowest socioeconomic groups are 3 times more likely to die before their 5th birthday compared to children from the higher socioeconomic groups. So the evidence is there that we do need to provide more financial risk protection and access to health care for the poor and the vulnerable. But funding is not enough. The NHIA Act of 2022 identified the sources of funding for the Vulnerable Group Fund. It mentioned BACPF, of course, because we already have that. We have the health insurance levy, the special intervention funds, interest from investments, grants, donations, gifts, and voluntary contributions. But we need to actually critically examine each of these recommended funding mechanisms to determine the sustainability and effectiveness of each of them in providing health insurance cover and expanding healthcare access for the poor and vulnerable in Nigeria. So on the next slide, you will see that the objective of our FSA was to see how much we can expand the yellow box, the yellow cube inside the bigger cube. those of us in the health financing space understand this diagram very well, that the extent to which you can cover people, that is population coverage, and cover services, that services coverage, depend on how much we can stretch our resources to cover more people and, of course, cover more services as much as possible. So we went out to assess how Nigeria can sustainably allocate resources for the Vulnerable Group Fund. We went to identify funding options in the current economic and political climate realities of our country. And then we went to identify optimization strategies and how to actually ensure they're able to implement the Vulnerable Group Fund. So our FSA framework is based on the Peter Heller theoretical framework that recognizes 5 major domains or pillars that could be used to generate fiscal space for anything, including Vulnerable Group Fund. So we have economic growth, because the macroeconomic dynamics are important, budget prioritization, earmarking revenues, improved efficiency, and of course, external sources. So our study covered all these 5 different areas. In terms of Nigeria macroeconomic dynamics, on the next slide, you would see that in spite of our growing debt challenges, Nigeria has been making more money and is likely to make more money from both oil and non-oil revenues. In fact, a couple of years ago, our non-oil revenue actually overtook our oil revenue, which is good news for us in terms of economic diversification. But then you would see what is not so good, which is the prioritization of health in government budgeting. You will see that one of the highest allocation we've had to health in recent times was 2023, when we have almost over 7% of the health budget allocated to health, This is in contrast to the Abuja declaration in this very city many years ago, where countries committed to allocating at least 15% of their budget to health. So we are contravening an agreement that we hosted. And of course, in terms of expenditure, you will see that it's even lower. And in terms of capital budget allocation, it's even lower. And that is the grim picture we found ourselves in. And so looking at prioritization is important, because even when our revenues are growing, to what extent do the federal, state, and local government prioritize health? And of course, if you dig deeper, to what extent does NHIA as an health institution get more allocations for its mandates? So we've seen that between 2017 and 2022, the health budget allocation ranked between 4 to 5%, went up to 7.24% in 2023. But for NHIA, we can only get more money to cover VGF if we have increased health budget allocation combined with an increased allocation to the NHIA. The NHIA has been getting consistently less than 1% of the overall health budget. As a matter of fact, the highest we've gotten so far was in 2021, when the NHIA got 0.28% of the overall health budget. And of course, has gone down significantly to 0.03% in 2023. So we looked at the health financing options. We've mentioned the overall economic dynamics, macroeconomic dynamics, and of course, prioritization. Now let's go look at earmarking revenues on the next slide. The challenge with earmarking is that it can be unpopular due to financial rigidities imposed on the finance ministry's ability to direct money. But the solution is to move away from hard earmarking to soft earmarking. We know that sometimes, if we are not careful, earmarking may not lead to an increase in the amount of money available for health. In fact, in some countries, it led to a reduction. Because all those earmarks were available, sometimes when they are doing budgetary allocation, they reduce the allocation to health. So this is a call to caution that while we are pursuing earmarking, we should keep our eye on the goal, which is to have more resources for health. Know that earmarking requires significant political capital and lead time. Sometimes it takes time to achieve those policy changes you need to earmark. And then, of course, if we get everything right, it can lead to substantial resources available for the health sector. So we look at 4 major types of earmarking. The BACPF earmark itself, currently at 1% of the consolidated revenue fund. What if it goes up to 2%? The law that establishes it says at least 1%. That means it can be higher than 1%. So the law already makes provision for possible increases. The pro-health tax that covers excise tax for alcohol, smoking, and sugar-sweetened beverages were also examined in this study. And we are looking at how much, these things are already being collected in the country, but not a match for health. So look at scenarios where we can get some money for health and for the Vulnerable Group Fund. Look at the mobile help time levy earmark, which was supposed to be in the NHIA Act, but was removed, before that act was approved. And of course, we have VAT. Out of the 0.5% of VAT that we have been discussing in country. The next slide shows the amount that could be accrued to each of these different funding mechanisms, looking at different scenarios. So you would see on this slide, BACPF earmark at 1%. Looking at our CRF for 2023, we got about 46 billion naira from that. If this earmark is increased to 2%, this will almost double to 64 billion naira. If you get 50% of the pro-air tax from alcohol, we will get over 134 billion naira. If you get 50% of the tax from tobacco, that will be 52 billion naira. If you get 50% of the tax from sugar-sweetened beverages, that is over 13 billion naira. And this very interesting one called remittances, this is diaspora remittances to Nigeria. These are the remittances for those who have jackpot and are sending money home. This, if we just say about 2% of it, it will give us 242 billion naira. In 2021, the remittances to Nigeria were over 9 trillion naira. And this was more than the IGR that Nigeria got that same year of just 1 trillion naira. And so let's keep our eye on the ball. This particular financing option has the highest potential based on this analysis to generate resources and fiscal space for the Vulnerable Group Fund. Mobile airtime levy, 40.8 billion. What if we increase it from 0.33 kobo per minute to 1 kobo per minute? It will shoot it up to 122 billion. What if we get 0.25% of VAT? Not even 0.5, 0.25% of the 7.5% of VAT gives us 84 billion. And of course, if you can increase that to 0.5%, we're going to get 168 billion naira. These are various financing options loosely analyzed for our information. So what we now did was to create scenarios, combining some of these innovative financing mechanisms for illustration's sake. So on the next slide, you will see this gradient that shows a baseline business as usual scenario where we just keep at 1% of CRF for BACPF. And of course, the NHI does not get all the BACPF money. We get 48.75%. So look at that, keep that in mind. So we keep at that, we'll look at that scenario that will still give us a coverage gap of 95%. That is where we are right now. If we go up a bit, we created a scenario we call the moderate or medium-term scenario, where we get some of these financing options in place using swap. It will move us up, but we'll still have a coverage gap of 67.5%. And then we have an ambitious scenario where we got everything we can dream of, at least for now, but we still have a gap of 19%. But you will agree with me that this gap has been significantly reduced if we can get this scenario. I'm going to go delve a bit more into detail on the next slides. So the next slide shows the green picture where we are now, the business as usual scenario. So the human beings in red are the people that are uncovered. And the ones in the other colors, any other color you see, are covered by different financing mechanisms. So at BACPF of 1% of CRF, we are covering barely 2 million people. So each image of a human being represents 1 million people. So when you see 2, that's 2 million. So BACPF now covers not quite 2 million people. And of course, every single other person represents 1 million people not covered. So our business as usual, this is where we would be. On the next slide, we grew a bit more ambitious and we call it the moderate scenario, where we're going to cover 15 million people. So the green marks, again, BACPF, we had mobile airtime levy to it, the purple ones, and then the VAT earmark and the social investment programs. So Nigeria has NSIP. We actually analyzed those as well. It was on the other graph I showed, where we looked at what if we get 20% of the social investment program. We all know about the National Social Investment Program, where money is transferred conditional cash transfer program. What if some of that money is used to provide health insurance coverage? But we do know that catastrophic health costs is one of the major determinants of poverty in Nigeria. Diseases tip people into poverty every time. And so we can make a case to all stakeholders in the Ministry of Poverty Alleviation that they should provide health insurance cover as part of the cover being provided to these poor and vulnerable people. So this talks about BACPF at 1%, 15% from pro-health taxes, 1% from diaspora remittances, 0.33 kobo from GSM calls per second, 0.25% of the 7.5% VAT, gives us 15 million people out of 83 million people covered. And of course, the red people colored red would not be covered. On the next scenario, that is the ambitious one, where we have all of these things. We have 2% BACPF fund. We even have counterpart fund for BACPF from the states, but this is actually a requirement of the law as well. We have earmarks of 50% from the pro-health taxes, the alcohol tax, the tobacco tax, and the sugar sweetened beverages tax. 2% of diaspora remittances compared to 1% in the previous scenario. We increase the telecommunication tax to 1 kobo per second instead of 0.33 kobo. Then we get 0.5% of the VAT, our 7.5% VAT in country, and then 20% of poverty alleviation funds for VGF. This will significantly reduce the uncovered people to just about 19%. So you would see people in all the bright colors are covered, and then we'll have those people at the bottom that are red not covered. This is not 100% coverage, but it is significantly better than where we are right now. But to get this done, we know it's not an NHIA only job. It's not even a Ministry of Health only job. It is everybody's job. And so we went ahead on the next slide to design or propose an expansion strategy. If we want to achieve an expansion of our fiscal space for the VGF, what do we need to do? So we identified some factors open to discussion that we need to ensure that we are able to engage our stakeholders and get the fiscal space expanded. So we have political economy analysis. Everybody will agree that you need to know who your players are. Who are the players that you need in the room, and what will be their incentive and their objectives, and how can we align with that? We also need an accountability framework. A lot of people say that we'll not be able to justify investments in BACPF currently at 1%. And so you need more evidence to show the impact of what we already have, advocate for more resources, and justify why the government will invest 2% of BACPF. We've not done a good job of that. I'm sure we all know about, what the findings have been about how we've been implementing BACPF. But let's have an accountability framework. We need it to justify investment and advocate for more resources. Then we need to develop investment case. And this is not just one investment case, but a multifactorial investment case development. We need to find a social investment case justification, economic investment case, and political investment case. We need to align with the government of the day and see how expanding VGF aligns with our government's priorities and buys more political capital for our leaders. We need to also have health priority alignment. The current administration committed to reducing diseases, to reducing pain, and increasing and producing health. And these are the things that we need. We also spoke about aligning with the Nigerian Health Sector Renewal Investment Initiative. Our strategy must take into account the feasibility of each of these financing mechanisms. It's true we have the numbers, but are they feasible in terms of political economy and implementation? And of course, timeline for the fiscal space expansion strategy itself. How long do we have? How long will each of these financing options take to implement? And of course, we need to recognize our stakeholders and use all of this, multi-sectoral approach to get them engaged and get fiscal space analysis expanded for the Vulnerable Group Fund. In conclusion, I will say that in the current economic state, all resources will be hard fought for. And we in the health sector have not been known. We are yet to excel in making these arguments historically. And so the time is now for us to get our acts together, get an accountability framework up and running to show evidence to justify what has already been invested and advocate for more resources and make evidence-based advocacy. We need to align with the pronouncement of the current administration. They have backed it with action, with increase in budgetary allocation to health and the willingness to reform our structure to absorb additional resources. The DG has talked to the shares over and again to expand our ability to implement BACPF and enroll more people. And so I would say that a window of opportunity exists for Nigeria to make an essential investment towards expanding the fiscal space for cover more vulnerable people in line with the Nigerian health sector renewal investment initiative. And I'll leave you with these words from the woman who discovered Kwashiorkor in Ghana. She says, we worry a great deal about the persons that we want to liberate from political tyranny, and we ignore those that we could and should liberate from the tyranny of hunger, ignorance, and disease. Thank you very much for your time.
She deserves another round of applause. For me, until, of course, we are able to settle for the DGF, we have not done enough for health financing. And just want to ask a little question before we go to the panel discussion. How many of us in this room today have received or anticipating to receive a call from a friend, from a family member, from a classmate, from a neighbor that they are in need of money to address a sick situation? How many of you? How many of you? Just today. So and while some of them begin to use this as a way to extort money from us, some are genuinely in need, and they fall within the category of which he has expatiated how we can get to them. So I do hope that your questions concerning her presentation will be one of those that we'll discuss, when we come to the interactive session. But for now, these white chairs must be occupied. And we have brilliant Nigerians who are going to speak to the next item on the program. I'll ask my co-convener of the UHC Forum. We called him Oga Health Financing. Now that is going to be chief, we better start addressing it as chief Health Financing Officer. I'm very happy to bring on Dr. Gafar Alawade to do what he loves doing best, evangelizing health financing.
Once again, good afternoon, everyone. You are welcome to this panel conversation. We have listened to the DG. He articulated clearly what the challenges are and the directions in terms of priorities. And it was very, very clear that the DG is very desirous of turn around the Nigerian health insurance ecosystem towards having improved coverage with equity, with efficiency and quality of services. Those are the 4 areas we're very desirous of seeing turnaround. And he did told us that he's not able to do it alone. He identified a number of stakeholder groups that will be very, very crucial towards achieving this goal. So that stakeholders group informed the selection of the panelists for this conversation. So to join me in this panel conversation is Dr. Simon Oyemachi, who is the chairman Forum of State Health Insurance Scheme. Let's appreciate them as they come, because the providers are very, very key. We have Dr. Jimmy Arigbabu, who is the healthcare provider from the Healthcare Provider Association of Nigeria. Then from partners that will be providing additional technical support. It's a privilege is mine to invite my sister, my boss, Elaine Barua from the HAPT Associates. Then HMOs are very, very important part of the ecosystem. So we have Dr. Leke Oshuni, the chair of the Health and Managed Care Association of Nigeria. Then our own, the face of health financing, WHO, Dr. Francis Okwuje, please come join the panel. Then in the past few months, stakeholders have done a lot of work to revive the umbrella group of non-state actors in Nigeria. That's a sector reform coalition. The privilege is mine to invite Dr. Mustafa Leki to join this panel conversation. Okay, we join us shortly. Dr. Simon, let me congratulate you and your team for a great job since we started the health insurance decentralization agenda in Nigeria. I was very excited when I saw the figure that the DG shows there in terms of additional number of enrollees that we've been able to bring on board to the state health insurance scheme. However, the largest room is the room for improvement. So how do we strengthen and reposition the state health insurance scheme to leapfrog health insurance coverage? And more importantly, to key into the vision of the DG of expanding coverage with equity and quality and so on. Over to you, Dr. Simon.
Thank you. Yeah, thank you so much, Dr. Gafar, and congratulations to every one of us, because in the past 4 months alone, I recall clearly that by December 31st, 2023, when we shared our data from the 36 states plus FCT, we had 8,107,000 plus Nigerians enrolled across the various programs we are implementing across the states, be it formal sector, informal, the equity programs, as well as the basic healthcare provision fund, which was about 23% of the operations of the state health insurance schemes at the time. From that time on to this point, by 30th of April 2024, the state health insurance schemes, earlier on I had said about 9.6, but I went to the database clearly to see it. And we have done currently extra 1.7 million Nigerians in the last 4 months across the various state social health insurance schemes. Because the data of the state health insurance schemes today stands at 9.8 million Nigerians. Of those numbers, about 2.7 million, because in the presentations in the room, PHCPF stands at 2 million, but where we are this moment is over 2.7 million Nigerians, poor and vulnerable, on BHCPF across the over 8,000 PHCs implementing basic healthcare provision fund. So what that underscores is a critical role the state social health insurance schemes have played and continue to play in our journey towards attaining UHC in the country. We were doing 49% of the total enrollments, but as of today, the state social health insurance schemes account for over 55% of Nigerians who have access to health insurance. So if we didn't have this decentralization policy, my thoughts would just run wild. Where would we have been? Something has happened significant. There's a major shift. There was poor awareness and there is still suboptimal awareness. The health insurance culture in Nigeria was almost non-existent. But the structure of the state social health insurance schemes, the presence in the 774 local government areas, which the state health insurance schemes have been able to bring to bear, has significantly improved the access to quality care. Now, with our structures, the issues where people will go to hospitals in the past, to healthcare provider premises to seek care, and then the enforcement or redress mechanisms will have to come from somewhere in Lagos or Abuja or Port Harcourt, as the case may be. That decentralization policy has helped to even drive home quality issues. When we cannot build trust in the system, your guess is as good as mine, you will not have returning clients. When there are no returning clients, those who manage because they have no options, probably formal sector enrollees whose contributions are deducted from the source will, rather than encourage others, discourage several persons, telling them that this health insurance business is a scam in the country. So with what we have tried to do, there is some form of behavioral change happening in the country. The innovative approaches we have tried to bring to bear have focused on persons who are poor and vulnerable. Across the various states, when you look at the cost of our premium, I use Lagos, for example, where the cost of premium is about 8,500. Delta, about 7,800. Anambra, Kogi, and the rest, about 12,000 naira. That is not the amount used to pay for care. It's a social scheme. Therefore, the state governments have put their money is where their mouth is, with the heavy subsidies that they give to our various schemes in the country to ensure that those who contribute that quarterly sum of the premium, it will be augmented from what the states governments are putting down. So that subsidy is helping us reach the component of equity. In Delta alone, we have about 1.8 million Deltans who are enjoying their equity program in that state. So information asymmetry, we know clearly, is the bane of health sector business. So it is prone to market failure. But because we are strategically purchasing, not somebody domiciled somewhere in Abuja or Lagos, but at our various state levels, we have various managers seeing that whatever we say we are rendering to our customers is what they are getting. That level of shortchanging of the beneficiaries has gone down tremendously. Where we have challenges of tariffs being fixed for so long, across the various states, we do cost-reflective review of our tariffs. There's no state health insurance scheme that their secondary and tertiary care costs, yes, the capitations may be low, but on the side of secondary and tertiary care, we do our best regularly to do cost-reflective.
Okay, Dr. Simon, let me interject. I think you have created a very rosy picture of the state health insurance in Nigeria. Of course, we know there are challenges, and you mentioned subsidy. We know very well that it's not all the states that release their equity fund. Later on, we'll come back to see what your forum is actually doing to mobilize those funding opportunities. Dr. Aribabu, the providers are very key, very crucial to achieving. So like Elaine and other corroborators, it's not only about the population coverage. Quality of coverage is very important, and ensuring that people access the needed care. How do we optimize the enrollees' confidence? Even the DG alluded to it that at this point, I think we are very low in terms of our confidence for obvious reasons. So what do we need to do to ensure that as we are desirous of expanding coverage, our enrollees have confidence in the system? What are those things we need to do?
For us, as healthcare providers, our first principle is that even the God you worship, you must believe that God before you have confidence in God. So the enrollees left for them, this idea of mounting the scheme is actually common. And wonderland this is happening. Number one, the waiting time is a problem when the enrollees come. I'm just being frank with us. Two, the time value of money is not being applied. And what do I mean by that? The premium ordinarily should be improved and should be increased multi-folds by now, so that capitation and fee for service can also follow, because it is the premium usually that will determine the capitation and fee for service. And not even the absolute value of fee for service, the benefit package should be appraised. There should be an appraisal of the benefit package, because the benefit package determines what the reimbursement will look like. Having said this, we also see among ourselves, have been encouraging ourselves to adopt as much as possible electronic medical records, so that we can seamlessly interface with HMOs and other stakeholders without much ado. Four, it is clear to us now that we have scarcity or dearth of human resource in health for this JAPA syndrome. So providers at times have to double the salary they are paying their health workers, including doctors, before they will stay. Even those who double for, it's only for them to collect enough money to feed their farms and go away. And outside this, we have been talking about health insurance under one roof. We had this scenario in Nasarawa State, where we started from.
So our policy making isn't as important as implementation. Usually when it comes to implementation, that is where our challenges come from. Again, data. It is not also easy to plan and take decisions when the data is either faulty or we can hardly even believe them. For example, our encounter data is key. Then those of us who think it's the otherwise, it's not the otherwise. 65 to 70% of the healthcare delivery, healthcare need is taken care of by the private sector. So no matter how we look at it, we should believe it. We should integrate the care of the private sector into this that we are planning. Outside of this, we're looking for capacity building, we're looking for grants, we're looking for loans to help this private sector who serve as their own local government. They make the road, they make the bridge, they make the well, they make the electricity, they make the security. No grant, nothing is coming from anybody. Yet you want to go and look for loan, say that double digit. I don't know whether they do triple digit, but we're looking for single digit, if not a write-off of that. And it is even time to have someone in taxation to some extent at the private sector level. Outside of this, we have issues of, what is budgeted to end? We need to tell ourselves this time around that the tertiary health institutions have no business with primary health care. They should concentrate on research, on teaching and tertiary referrals that we do for them. Let's concentrate on the primary care level. You will see the growth geometrical of the enrollment of this our enrollees that we're looking for in health insurance. Outside of this, who will you pay money directly out of your pocket as a provider that will not be happy to just collect that money and ride on, except you just want to be, in fact, as faithful as Jesus Christ or Muhammad in taking care of the poor. Otherwise, you will take care of somebody who has the raw cash ready. And the reason is simple, it's not far-fetched. Number one, somebody wants to delay your payment. Number two, even what the person wants to pay you is not the time value of money. Actuarial or no actuarial, some of us don't even seem to have faith in that actuarial determination, because the inflationary trend coming up now is only the health sector that seems to ordinarily be immune from being reviewed or from being increased for all that is happening on other sectors, including tomato sellers. Everybody knows when to step up. But in the health sector, it looks like the opposite is the case. And apart from this, we should be having interface with providers from time to time. We should not assume that all is well. Our HMOs need to have synergy with the providers. We should all work together. It is the two parties that will help to increase the confidence of the enrollees. We make them to do. Then after those days, it's a domestic name. It's a domestic language for people to say. Why not NHIA? Why not that insurance be domestic? We should go all out for advocacy. People like Antimoji, they're on ground. These are people who can even talk to the media world. To use that language as a common language, we need to use even the Nollywood. We need to use anybody that can even do drama display for us to tell the average home. Suppose you have an accident now, who takes care of you and you have insurance? We are in Nigeria, unlike UK and America or other advanced countries. But I want to say that synergy, we need collaboration and not competition. Competition is a self-centered event for selfish growth, but collaboration is for generality of growth and development. Thank you very much.
Great, thank you very much, Dr. Aripa. Very, very insightful stuff. Dr. Leakey, the HMO is at the critical interface between the provider and the health insurance agency, and of course, you interface with the enrollee as well. What do we need to do differently to ensure sustainability and value for money of the health insurance? HMOs has a very, very important to play, and there have been a lot of challenges in the past, HMOs relationship with the health insurance. What do we want to do differently to ensure that we have a smooth relationship, and at the same time, we ensure sustainability of the health insurance scheme?
Thank you very much. Well, in effect, HMOs are more or less the eyes and the ears of the authority in the outside world. So we are like soldiers. We go out into the field and ensure that value for money is being delivered. But with regards to scaling up,
how do you do that specifically?
So we are the ones who actually pay the sums of money to the providers. And of course, that gives us some leverage because we can do quality assurance. We can manage on one-on-one basis secondary care clients. We can field reports from the primary care level.
When people complain, the complaints usually come to us, and we analyze what's happening. We send out teams. We ensure that things are done according to stipulated practices. So we're just the military arm of the NHIA, as it were. With regards to scaling up the entire industry, I'd say, I was a little bit disconcerted that the DG did not mention finance. But I see that he had left it to the NHSS to do that, and a very thorough job indeed was done. You cannot provide free healthcare. There's no such thing. Healthcare must be paid for. The providers who have set up their hospitals, over 6,000 of them nationwide, those are investments. They've made investments and they expect to recoup some value. So it would be inequitable and unfair to say, treat people free. Of course, then premiums and tariffs have to be proportionate and at such levels that value can be accrued by the investors. One major point that was made during the NHSS presentation was the issue of the country actually growing richer. I became interested in the national budget during the government of Shehu Shagari. And the national budget was then about $25 billion. In today's money, if you multiply the exchange rates by the amount of dollars that are being invested, you get about the same figure. So even though there were only 70 million people in Nigeria at the time, the budget then is the same as it is today. So it is critically important that the nation becomes wealthier. And this is the first presentation I've ever seen where that fact is mentioned. If the nation is wealthier, then more money will be available per capita for the care of the needy and the vulnerable. I think I would just...
I leave you there. In the past, there were a lot of allegations against your members in terms of delay in actually releasing funds to the health facility, not releasing the funds and everything. As an association, do you have like a standard to which you hold your members against in terms of this is the standard or this is the code of conduct that you have to, as a member of this association?
Well, there are many reasons why it may seem that we are not releasing funds. But the truth of the matter is that there is a lot of vetting that goes on in our processes. For example, I have a provider bill on my table, which for care that was given 4 years ago. And it's been demanded that we should pay for that care, even though the rules stipulate a closure after a period. So bills are not always valid. We get late bills from providers. We get bills that are not appropriate from providers. There are over treatments, there are under treatments, there's over investigation, under investigation, there's non-treatment. These are very complex issues.
So you're completely absolving your members of blames, right?
Completely. We're not without blame. But I think a robust IT system would eliminate 99% of it, because you would then be able to see at a glance who's telling the truth and who isn't. I hope that...
Absolutely. Thank you very much. So Elaine, there's no way we can run away from the issue of finances. Even Dr. Lege mentioned it, and actually appreciate the great analysis there. But beyond policy analysis, finance analysis, how do we move from policy analysis to policy actions? A number of areas were identified as a potential opportunity for us to mobilize additional resources. Are there practical advice you want to give to NHIA in terms of how to pursue some of these areas?
Gafar, first of all, I'd just like to give full credit for that excellent presentation that Bola gave. It was very much a team effort, and Dr. Gafar and DGI Consult were part of that team effort. So I think almost Bola had the easier job of talking about where the sources of money are and left me with the job of explaining how do we actually get access to that money. So I have some thoughts. About this. First thing I'd like to say, I've got 5 things to say and I'll try to say them quickly. First thing, the strategic part in this strategic stakeholders engagement, the strategy is important. Let's be realistic and grown up about this. This money, everybody else wants it. It's a competition. It's a competition you have to win if you want that extra money for health. It is a competition. Therefore, you have to be strategic. Infrastructure wants that money. Power wants that money. Education wants that money. Everybody wants that money. You have to be strategic. So to be strategic, you need to do 2 things. You need to assemble your team and you need to know your competition. You need to understand what is your competition doing that's doing a better job of what I'm doing. This morning, we talked about enrollment. And I hope everybody, if there's one thing you take away today, it's that enrollment is not the end game. The end game is improved health status. Enrollment starts us on the path of access and utilization of quality care that gets us to better health status. Enrollment is the beginning of the journey. It is not the end. In the same way, I think, when we're doing our advocacy, we're asking for money, we're advocating for money, we can't be telling people that we want to increase enrollment. Who cares? Is that a powerful argument? Really think about it. Going to the VP or the president or the private sector, we want to increase enrollment. Is that a powerful argument? It's not. It's what that enrollment gets you that's the powerful argument. Use your data and understand, what is it getting you? Is the argument to be made decrease maternal mortality? Is the argument to be made more children getting immunized? What is the argument that works? Use that argument. Be strategic. And it's a different argument depending on the sector that you are approaching for finance. There were so many things presented up there. Telecoms, increased basic healthcare provision fund, pro-health taxes, remittances. If you're going to make that case for remittances or telecoms money, I don't think enrollment is the argument you're going to use. You need to make a business case because somebody else can use that money to build roads, to electrify. So what is your business case when it comes to health? What do we mean when we say develop a business case? We mean develop a case that explains why investing this money in the health sector is going to increase our overall economy. People have mentioned that today. Labor, it employs people. Infrastructure, you build things, you support and maintain those things. Pharma is part of the sector reform plan. We have pharmaceutical industries here. Why are we not working hand in hand? This money doesn't need to go outside the country to buy drugs. We have perfectly good pharma companies here. So if we can pay for that, we can pay for drugs, they can produce the drugs, everybody benefits. It's a win-win situation. So make the business case that's going to resonate to the people who make decisions, whether it's the House of Assembly or the executive or the governor, make the business case that resonates. The third thing I want to talk about is accountability. Recently, we had states come together to talk about their experience with running the SHIAs and partnering between the SHIAs and the agencies for primary healthcare development. Nasarawa made the point of accountability. Going to the governor and saying to the governor, here's how many people we've enrolled. And the governor responding, that's it? That number's so small. You need more money so that you can do more. And then going back and saying, here's what we've done with the more. Basically, they reported themselves. Nobody told them to bring evidence. They brought it themselves. They bring it on a regular basis. Now the governor is engaged because on a regular basis, they bring their enrollment numbers. You have to be prepared to report yourself. If you're not willing to show your data and demonstrate what you're doing with it, then don't expect to get more money once a year when you come with your budget request. You must report yourself. That's what we mean when we say accountability. And accountability starts with you. Don't wait for somebody to call you to explain what you're doing. And then the last thing I want to say is prioritization. We can't do everything all at once, okay? There were many different options that Bola put on that slide. And when she finished, she said the most ambitious option would cover for 57 million, and there are about eight different sources. If we had all of those sources tomorrow, we would not know how to spend it. We would not be able to consume that money. So let's balance what we're asking for with what we know how to spend. Let's have a strategic plan that says we're going to grow from here to here. This is how much money we need. And then when we keep growing, we need some more money. But let's not be throwing out random numbers. I, for one, and I don't mind saying it on this platform, I'm tired of hearing the 15% from Abuja, from the Abuja targets. I really am. Tell us what you need, use it, account for it, and then come back and tell us you need more. That's what ministries of finance and economic planning want to hear. They honestly don't care about the 15% Abuja target. Facts. I defy you to find somebody in the Ministry of Economic Planning who gives a toss about that 15% target. Be realistic and do the work to talk about what you need. Don't talk about the Abuja target anymore, and be accountable. So those are the things that I wanted to say. Have a business case, prioritize, be accountable for yourself, and be strategic about how you go about doing it.
Great. Thank you very much, Elaine, for... Okay, thank you very much for providing very great insight on what we need to do to move from policy analysis to policy action. Thank you very much. So Dr. Francis, you listened to the DG, you identified availability and use of data for decision making as one of his key enablers. And that is what we find challenging here. So I want to find out from you, because you've been interacting in this space for long, what are those factors that actually militate against having access to data in the health insurance space and utilizing that data for decision making? What support does NHIA need to ensure that decisions are based on data? Professor Obina said in Nigeria we do faith-based decision making, not evidence-based. So how do we move from faith-based decision to evidence-based decision?
Thank you. I'm happy that the vision of the NHIA that the DG presented this morning had data at the center of it. And that's not quite surprising, because again, in the blueprint of the Honorable Coordinating Minister for Health in the Health Sector Renewal Investment Program, data is at the center of it. And you truly wouldn't be able to make any difference in any system, especially in the health system in Nigeria, without also making a difference in terms of what we can do differently in data. And this data we're looking out, based on what my sister Elaine had just mentioned, it's not just going to be program data. We're supposed to be looking at financing data, and financing not just about how much we need, but truly what outcomes that we are looking out for. What are we solving for? And within the society and within the population, what do we need to gain? So it means that our investment cases must be there to engage with all the stakeholders. But the challenges we have along the continuum of input, process, and output, but not just output, but utilization. So you agree with me that what we have done so far would really end around the output and utilization we do not emphasize a lot in the health insurance ecosystem. Utilization is important. But for the policy makers to take decision, evidence-based decision, and not faith-based decision, just like you mentioned. For them to be able to do that, they would need to see what's on the ground, and then see perhaps what potentially they will be missing out if they do not take action. And this has really helped. The case of Nasarawa is there, the case of Anambra, and the case of Imo even recently, where the governor was moved to commit resources for the enrollment and access to care for the public sector was brokered on the table of evidence. And the governor himself said, if this is true, and these were his words, then I will have to commit and move forward to providing the money, and he provided the money. Well, part of the challenges also is that we do not communicate effectively with the citizens. So how do we ensure that the citizens have access to the data we generate here? And then how does it connect with them? So if you're saying that it's only about 10 million Nigerians that are covered on health insurance in Nigeria, what does that mean to them along the street? Why should they collect? And that is also the reason we need to bring it lower down to their levels. Again, when we had an engagement with a few market people in one of the states, so what we showed them was how the high out-of-pocket expenditure is actually showing up on the catastrophe. So how they're falling into poverty using health. They were like, no, we need to engage. And they themselves requested for an MOU to be signed for them to join health insurance. Beyond that, we would need to convince ourselves that we need to do things differently. How do we do that? It's ensuring that we reduce the hyper fragmentation in data management in the health insurance ecosystem as today. The government, when I talk about government, I talk about the NHIA. Prior to this time, there wasn't access to data from the NHIA. The NHIAs were also holding on to their data. The HMOs were holding on to the development partners and others. Now, with what is going on over the last few years, I think this has under the health insurance under one. The second is ensuring that we have capacity. And this capacity is institutional, both institutional and individual, ensuring that we have appropriate systems within the organizations to manage this. And finally, we look at the infrastructure. When I think about infrastructure, I'm going to include tools and technology that is needed. People have moved and managing data have really moved. So we're talking about digitization and all around these days to an extent that data management can be more cost effective when you use technology. What are the opportunities? The opportunities is the number one, health insurance, so that one will be second, the sector-wide approach that the Honorable Minister is pushing right now. I'm happy the NHIA is and the State Health Insurance Agencies are integral to that initiative. The second is integration and the collaboration of efforts along these lines. I talked about policy and strategy, direction, capacity, and infrastructure.
Great. Thank you very much. Thank you very much, Dr. Francis. I think that's very, very helpful in terms of understanding the situation. What do we need to do and opportunities to leverage to ensure we're able to generate data, not only generating it, but using it for decision making as well. Dr. Mustafa Lekki, once again, congratulations. He's the brand new chair of the Health Sector Reform Coalition. I think the coalition is very, very lucky to have him at the helm of affairs. So when the DG made presentation, actually look at different sectors and look at civil society and identify 3 important areas: awareness, advocacy, and accountability. And from the conversation so far, in fact, I think you should be developing your advocacy agenda right away, because there are a lot of conversation around financing. We are not able to improve population coverage, service coverage, cost coverage without mobilizing additional money. How does the sector reform coalition, considering your very, very wide reach, almost all the non-state actors in Nigeria are part of the sector reform coalition, how do we want to mobilize that pool of stakeholders to help advocate towards achieving the goals highlighted by the DG?
Thank you, Dr. Gafar. I'd like to start by just drawing our attention to this issue of accountability. We use this concept very loosely, but I think we need to use it in a way that is a very, very inclusive concept. When we talk about accountability, we're accountable for what and to who are we accountable? I think we'll say straightforwardly, accountability is to the people who are the beneficiary of our services, you and I and others who are outside of this room. So we need to look at issues of what we do or even don't do from the perspective of rights, fundamental human rights in health. How are we attempting to raise the bar of accountability to address the rights of the people that these services are meant for? So we need to do that. And so when we talk about accountability mechanism, for example, to what extent are people who are ordinary people like us, who represent the CSO, right holders, are involved in those accountability measurements? How do we set the targets and the results we are aiming for? How do we say, what make you think that the numbers are more important? What are the issues? What about the issues of satisfaction and acceptance and trust and belief in what you are doing, to be able to pull the people to go along with you? If there's serious deficit in terms of trust, we know that it cuts across many sectors, particularly in Nigeria, in the health sector, where people don't trust the health system. They don't, because of the failures that they see every day. They're not sure if you go to the hospital, you are going to find the nurses or the doctors or the medicine or the cost that you can afford. So people are disillusioned. So you need to rebuild this trust. And the way to rebuild, to make sure the people who are the right holder are part of any accountability mechanism you are setting up, is determining what are the end results that you're actually trying to aim at. I don't think we are doing that. And that's also a failure of how the CSO, like the Sector Reform Coalition, have been involved. The involvement needs to be intentional and not a sideshow. You shouldn't be planning, executing, reviewing, monitoring, and evaluation and writing report without intentionally including people who are representing the rights holders. That is the vehicle. And all the speech that we had today, we have not listened. I'm happy to hear what the DG said about issue of advocacies, awareness creation, and education. That is the right way to go. We have to be intentional and be part of the plan. I also want to talk about something related but a little bit different, which is the issue of the NHIA need to also be very intentional in the area of the digital NHIA. The digital NHIA is very important. There is any reason why now the NHIA does not have an app in the making that will allow people in the remotest part of the country to do a number of things they need to do. We transfer money easily, right? Through SS code or various other codes, various people are downloading and using even the remotest part of the country. That is forging inclusivity. Moving the boundaries of inclusivity beyond Abuja and Lagos and the state capitals to the remotest part areas such as Auchi and beyond, for example. So why are we not doing that?
I understand the Auchi part.
Thank you very much. NHIA should embark on this digital expenditure of ensure there is an app that allows people to register You have a fantastic gift ship program, which I think will actually bring in the informal sector. And that was one of the best things that has come out of NHIA in recent time, the gift ship program, which is the group insurance family program that anybody can just sign on to. So you put it on the app. So anybody, wherever they are, those who want to enroll, they can easily, do that. So you need to make sure you do that in a way that is nimble, flexible, user-friendly, and I will bring in every other person that is out there that is not covered. I also think that we need to ensure that there's an intentional involved community. I've said that earlier. And the way to do that, like I said, is to make sure the CSO are not just recognized as key stakeholders, but they're involved from the value chain, from the beginning of the process to the very end. I think those are the things that I feel that are missing, that can easily be done, that will take us further in this NHIA, taking it further, ensuring that it's beyond numbers, but it's also the issue of satisfying, issue of people who are happy with the system, who are happy to tell you that they're actually benefiting, from the NHIA program. Thank you.
So thank you very much, Dr. Lekki. Honestly, I totally agree with you. We have to be intentional about how to engage the civil society, and digitizing the system increases transparency and accountability as well. So at this point, we'll take a couple of questions or contributions. We'll not be able to take so many because today is Friday. We have to close very soon. Questions, contributions? Okay, I can see one hand, two here. Okay, we have the four. Now five. So can somebody help with them to move the mic? Okay. Can you please give him the mic? Yeah, our chief in Barbariga there. So please let's be straightforward and be brief about the question, please.
Well, listening to these the most important thing is for us to have the digitalization and the integration of database across sectors, because there's a lot of fragmentation. Even in national, we have over 19 million households in our database, but now that's become eminent, and it's a presidential directive that each household and member in the household, before benefiting from any government intervention, must have a need. And need is now becoming a central conveyor, not for identifying individuals in Nigeria. So our database, we have prime engagement with NHIS, and I believe for us to achieve the target, I think we still have to fall back to the National Social Register because of the coverage in terms of number of a household and individual level, because of its coverage in terms of the locations, communities, local government, states, and now we are adding quality. The quality we are adding is the need, whereby there will be an identifier, and then the targeting will be effective. So the delivery of services will be whom deserve it. So, and the integration, just like what the HMO said, we should make concerted efforts in building a system where there will be a little human interference, end-to-end, inscripted. That's what will be, incorporated in the new NHIS. Thank you very much.
Thank you very much. That's very helpful. Yeah, you could.
Okay, thank you very much. I just want to speak a little about the issue of trust. Trust is a function of experience. And so if we must build trust and get people to trust health insurance in the country, the quality of service delivery must be improved. That's the barest minimum, because we all know that our experiences assessing services, even to some extent of today, in private hospitals, you also have those challenges. So health service providers must begin to look at how they play their role in ensuring that service delivery is placed at optimum level. Then the other thing is that in terms, she spoke extensively around the business case as a driver for expanding investment in the VGF and other demands for resources. But it's also to say that in terms of data, you also need to be able to connect health insurance and the state of our health service delivery. So if we are talking about dealing with the issues of malaria, for example, HIV and AIDS, we need to be able to connect difference that we are making in these disease burdens with how health insurance is doing that. That way, people can begin to see the overall picture in terms of this is a pathway that will work towards achieving universal health coverage. Until we do that, some way we talk about health insurance as if it is removed from the broader health system. So those are narratives that we need to start.
I think that is noted. So, can somebody quickly? Thank you. This way.
Hi, thank you very much. My name is Dr. Lando, I'm reading out the States. So thanks so much for this forum, and I want to appreciate the states. Sorry, it seems to be coordinator on health insurance. I so much like about the translation of the health insurance. I came to the States, I run an organization in the States on sickle cell. I'm able to partner with the state health insurance to provide basic health care for sickle cell warriors, and it's so wonderful. I'll maybe to see you after this program and share more about testimony. So the digitalization is very important and it's very working. I just have 3 questions, and also for the presentation area on the vulnerable board. I think it's my first for hearing about it. I would have loved to hear more about the still works and what I decided. She's made mention of poor and vulnerable people, but what are the people that are really talented and how do they get to the people that are really working with? Then I've been in Abuja for like a year plus now, and I can tell you that health insurance in the States is different from health insurance in Abuja. I really don't know why there's disparity in that. Some tests are being carried out like free, the online NHIA is being free of charge. But here in Abuja, they have to pay, it doesn't cover. So I really don't know the reason why there's disparity in this. And also, I don't know if you can incorporate sickle cell. Nigeria has the highest volume of sickle cell in the world. And so we're not really talking about sickle cell, we're hearing about malaria, HIV, tuberculosis, but we're not really talking about sickle cell in Nigeria. And we have a lot of warriors sickle cell patients in Nigeria. How can we incorporate them to the health insurance and also increase awareness about sickle cell, genotype, compatibility, and so on?
I think we'd like to stop here. Thank you very much.
Accountability is really helped me, and I think I will take that into action. Thank you so much, ma'am.
Okay, thank you, the young lady from Ekiti. Okay, thank you, Ari.
Thank you so much. Panelists, Dr. So I want to direct the question to the head of shares and also to the HMO. I know that for most medical insurance needs, we are not really engaging with HMOs. And because of the notion that, we can take care of it ourselves, we can manage, enrollment, we do all of this stuff. So that is good. But when the population begins to grow, coverage begins to expand. The health agencies may not be able to manage things again. It becomes about so what are we doing recovery and how we collaborate with the HMOs to be able to manage this. Secondly, for MPs at the level of beneficiaries at the level of facilities, most of them don't know what to expect from facilities. And that's why they don't have confidence in the scale. So what are we doing about enlightening the enrollees, getting guide that will make them understand what the health insurance center? And that's what the NHS is doing through the enrollment all meetings. And I would like to describe that for those that are here, that enrollment meetings that includes providers.
Apologies, may not be able to take that explanation, please, because of in the interest of time.
Right,
yeah.
So lastly, is what are we doing according to the share? What are we doing about IT, ICT? Most of our processing are still manual. Some partial digital, or most manual. What are we doing? Because we want that insurance to get to the grassroots. Someone will be able to register from start to finish without going to health insurance. You know, be able to do that. If you don't get to that aspect, then we'll begin to have some of these problems. Thank you very much.
Thank you very much, Abayom. And the last one from this corner, I can see Joy as well. Joy is going to be the last person. Then we'll come back to the panelists.
Good morning. Thank you for this opportunity.
It's afternoon already, so.
I advocate for increasing treatment for acute malnutrition. Nigeria is in an acute malnutrition crisis. As we sit here, 5 million children under 5 need treatment for acute malnutrition, but right now, only about 1 million have been treated by donor funding. So you can see 8% funding gap in that sector. So everything, you know, that is being said here is pertinent to my sector. So as of interest, I want to ask 2 questions. We've talked a lot about things that are very, very important, but nobody has mentioned anything about research. The DG talked about tweaking the benefit package. I agree with him entirely. How are we going to do that? Somebody going to sit here in Abuja and decide what Nigeria is doing, or do we need to go into research? It has to be intentional. We can't leave it to the academia. We have to design what we do. We need to find out about that. So research is very important for going forward. The other question I want to ask is remittances. Do we currently tax remittances? These are private funds of Nigerians resident abroad. We tax them currently. If not, why do we want to tax them now? If we do, it's a progressive. You know, one of the functions of health financing is also to make sure that the funding we're getting for healthcare is also, you know, from equitable sources. So those are my 2 questions. Thank you very much.
And last one from Joy there, quickly.
Thank you so much. My name is Joy, so I work for Options Consultancy Services. I think we've talked a lot today about covering the vulnerable, but my question is how also do we target the informal sector who can pay? And I would like to direct it to the person from NHIA. Are there some strategies that you've seen that works to get those who can pay to contribute? So that's a lot of resources that is also being missed out. And then maybe a question to the DG of the NHIA. I love to see the goals, but it would be good to break it a bit down on these key steps that are taken for each of the goals around coverage, equity, quality. What are the key steps we are taking to achieve our target? And when can we expect to see that even as partners so that we can align properly? Thank you.
Okay, thank you very much, Joy. I don't know whether did you want to start to say 1 or 2 things with regards to the last question before we now ask the panelists. Okay, we should continue with the panel discussion. Okay, thank you very much. So you've listened to questions and contributions. Some are actually contribution recommendations. Oh, somebody should give the rock the the mic quickly to. It's from the constituency. That's why you are very concerned, right? Yeah.
Good afternoon. My name is Dr. Rock. I'm the Director General of the Edo State Health Insurance Scheme. My question or recommendation is to the National Health Insurance Authority. During the presentation, we had over and over again fragmentation. And I want to sort of allude to what the woman on the panel talked about, having to present your case so that you can get more coverage, you can get more people onto the scene. The across spectrum of care, it's what we're doing now. We find out that we use mostly government hospitals, and somebody alluded that 80% of care is private practitioners. What is the NHIA doing to quickly get private practitioners on board? Not just health service providers, doctors, pharmacists, diagnostics, those spectrum of care should be on board so that enrollment access is very for any organization that wants to play. And so once you have those spectrum of care across board from pharmaceutical to diagnostic, then you can also. My second recommendation is that we know that different states started at different times, and then we have different tariffs. But one of the key things is that you pay for a service and you don't get a service. We find out that happening in a lot of primary care agencies because they are not doctors, they are not personnel. But also, if we say we are a country and we can have some integration or interoperability, we can all adopt benefits that are readily available. We don't have to wait for online benefits. So if Anambra, for example, is treating malaria for 5,000, if somebody from Edo State goes to Anambra, you can treat that person, and at the end of the month or 30 days or whatever the time is, you come back and say, okay. But to wait to say that we must harmonize our pricing, it will take 10, 15 years, and we must start from where we are from. So I thought I should bring that up, and so hope that we can achieve that in the quickest possible time. Thank you.
So what we are going to do, we are going to go to the panelists. We encourage them to answer any of the questions probably directed to them or they are interested in answering, then give their last thought in terms of from their constituencies, how do we support the DG to achieve those 4 important high-level result areas that you mentioned. Let's start from Dr. Lekki, sir.
Okay, thank you very much. Very quickly, I think one of my key recommendations about NHIS needs to have a digital app. By now, or working on it, we resolve a number of the issues that have been raised here. It will deepen penetration. It's nameable. People can use wherever they are, depending on the flexibility and the parameters built into it. It will help inclusivity. It's simple, and a lot of it will also increase transparency, and which is important in terms of dealing with issues of rights to health, which is where we come from, the CSO. And I think also the inclusion of CSO intentionally in the whole spectrum, like I said, has to be intentional from the NHI as well as from the state. And for my brother from Edo State, Dr. Rock, the NHIA, normally will approve different providers, whether they are private sector or public sector provider, whether they are pharmacies or primary health care centers. So that has been from the inception. So you need to expand the level of facilities providers who wants to be assessed, and then they are given the accreditation approval from NHIA, that they can begin to provide service. Thank you.
So thank you very much, Dr. Lekki. Dr. Lekki, if you can do it in less than 2 minutes.
Yes, I'm sure I can do it in less than 2 minutes. I'd like us to return to the issue of finance. One of the main reasons why we are here is that Nigerians are not a nation of taxpayers. I've mentioned this to the DG before. Tax to GDP ratio in Nigeria is between 6 and 8%, compared with the European countries that have between 40 and 50%. I think France is 47, South Africa is 26. So I won't say we are tax evaders. I'll say we are tax avoiders. Right now, the mandatory clause in the scheme cannot be enforced, or is not being enforced. If you are driving a car and a policeman stops you, one of the first things they're going to ask you is for your insurance. That has become part of the culture in Nigeria. And this could be third party or comprehensive. I think we need that kind of compelling force of government to make laws that will sweep funds, much needed funds, into the vulnerable group fund. But most of all, we should widen and deepen our tax net so that we're not talking of a budget of 30 trillion, but the budget of 120 trillion, in which case the BHP fund will cover almost everything we need. I think I'll just stop.
Okay, thank you, Dr. Lekki. Dr. Simon, a couple of questions were directed to you. Can you answer them and at the same time give your last thought in terms of how to support the NHIA vision?
Thank you so much for the questions. The first thing I want to say is that the states have actually been operating state health and social health insurance schemes just for 5 to 6 years. And even in 5 to 6 years, we currently account for over 50% of the enrollment base of Nigeria. It tells that that is the future. That's the way to go. Having made that point, I want to say that across the country, we have decided that we must learn from the implementation strategies of our parent body, the NHIA. The decision not to use HMOs to implement across many states was very intentional. But we collaborate. The health insurance space is so big. Across various states, you find that different roles are assigned them doing third-party administrator jobs, claims management, marketing, and business development, quality assurance, and what have you, people service, and those kind of things. But the same way, nobody came down from heaven with knowledge of health insurance management. The states are building capacities. Over the years, we have grown our capacities, all manners of trainings. But at this point, we still have some capacity gaps. Next week, we will be in Abuja. Because of the changes in government, we have about 15 new CEOs. LHSS is supporting us to build the capacity of those CEOs. And we do our quarterly meetings where we try to share experiences. That's why I said something when I was talking. We started what we call adoption model in Anambra. But today, Anambra cannot match Lagos State in implementing adoption model. We shared it, Lagos refined it, and where they are today, we may not catch up. That's the beauty of that forum. We try to build technical capacities, and then the NHIA is very intentional about making sure that the capacity of the shares beyond the CEOs are built. So that is to say, as we grow, we learn, we improve on what we are doing. Only 6 of our states do not have a health insurance management platforms at this point covering formal sector and what have you. We do end-to-end in about 14 of our states. In Anambra, in Kano, you don't see papers from where care is rendered to the end, even to the registration. If you punch on your digital phones at this point, I will land. Sorry. When you punch *6700 *005 hash, that one is for Anambra. You can start in your bedroom, register yourself till the end. You do *6700 *006 hash. That is for Lagos. And different states have keyed into that investment that the World Health Organization, with support of European Union, did for us. So across the states, we are leveraging technology. That's why we can tell you clearly, these are the numbers. This is where the states are. We make the cases to our various state governors to say, see the money you've given to us. This is the much we have done so far, and see the results. For sickle cell disease, we have laws across various states that have mandated that persons living with sickle cell disease should be treated. But then we hope that a lot more states will get to do those kind of things. But rest assured, NHIA, that we will go shoulder to shoulder with you on this journey until Nigeria attains universal health coverage. There's no federal citizen anywhere, but we will get there. Thank you.
So thank you very much, Dr. Simon. With this great work that we are doing at State Health Insurance, I hope we are tracking financial protection as well, so that people are not just covered in name, and when they go, they only get paracetamol. And okay, I'm very happy that we are doing that. Okay, great. So Dr. Aribabu, quickly, in terms of what are your final thoughts, or if you have any response to any of the questions, but final thoughts in terms of how do we support the vision of the NHIA?
Thank you very much. We belong to HTPAN, Healthcare Providers Association of Nigeria, the common umbrella for doctors, dental surgeons, lab scientists, pharmacists, radiographers, nurses, and so on and so forth. So it's this holistic approach under one same umbrella that should be and will be, by the grace of God, approaching the DG for quick results, not individual carrying walking stick coming. How many of them will the DG be able to attend to on one-on-one? We really want to make sure we do holistic approach. Having said this, it's also not likely that to give somebody money for Mr. Biggs and is going to tantalize her, you may not get the result. We're talking of quality healthcare delivery. Quality is not free, it's not cheap. And that is why we are saying about 2006, about 8,000 providers were accredited nationwide. One will have, by NHIS then, one will have expected triple or quadruple of that number by now. But because we are crippling, and why we are crippling is so easy, we will want to advise, and we're going to support the DG to remind him of his oversight function on private health insurance. Apart from the public health insurance, the private health insurance is already captured in the NHIA Act of that 2022 to the extent that they will be the regulator and direct our costs as the case may be. A situation also where the PHCN is giving our colleagues about 23 million naira NEPA or whatever bill to pay in a month. Who are we going to spread this money on the enrollees who are the opticals? Some of us are giving 6 million or 9 million. How can we, they put us on band A without seeing to see what we are operating. Some of us don't even have the oxygen cylinder. Yes, they put you on band A. You see, these areas are the areas where we are not actually doing things that are commensurate, and it's going to be very disastrous. Yeah, out-of-pocket payments, nobody's trying to eradicate it. You can only reduce it a little about 30%, which would be acceptable. We're talking about 70% is abysmally high. And saying this means at our level as providers, we will keep advocating, we will keep singing health insurance as the only way out. It's even a win-win situation. When the patient comes and they cannot pay money, and we are saying pay before you go, they vandalize our hospitals. They break our windows, beat our doctors if need be, because they cannot pay from their pocket. And they see us as very wicked. But if they have health insurance, they're going to be the best of friends that we can think of. Outside of this also, I can say it proudly here, but with dissatisfaction. About 20% of our colleagues are either leasing out their facilities now, converting to hotels, or outrightly selling out because they cannot break even as it is now. And it's because the services we render are not being properly reimbursed. We need the value for money. We need the review of what we're being paid 12 years ago. This is 2024. You can't be paying us what you paid us in 2012 and expect that we're going to embrace quality as the best option. When the mouth is going to pay from the pocket, it's really struggling the bed of admission with me. And finally, I want to say this for the consumption of all of us. Please, and I begin to beg, please, the laborer deserves the payment for services rendered. That is the shout and the tears of providers nationwide. The HMOs that our brothers, let them also work in synergy to work with us. We no longer want to see HMOs that are owing. We beg the NHIA to publish periodically accredited and approved HMOs before we see another TB HMO that will take our money and run away. Thank you very much.
Thank you very much, Dr. Haribabu. So, Elaine, can you do in less than 2 minutes? Thank you very much. Exactly. Yeah, cross-subsidization of time, right?
My colleague from NHIA that who spoke to one integration of the health insurance data to the wider health sector data, and then Dr. Dan was also speaking to research. So I think it is important to mention that the NHIA has actually started in the right direction in terms of how to manage data, and this is under the Health Insurance Management Information Systems, HIMSS. And over the past 1 year, there has been very wide stakeholder engagement in ensuring that the fabrics of this HIMSS is properly developed with all the stakeholders. And at this point, I think the tools have been developed just to begin to work with the state social health insurance agencies and various stakeholders to begin to implement. There are 4 things it's going to do. And the very first one is to ensure that there is on-demand quality data that anybody can use within the health insurance ecosystem to make decisions. And these decisions are the levels of the policymakers, like I said, or even within the NHIA and NHIAs, to be able to refine their operations to ensure there is quality service that is provided. And the research that, and this is coming to Dr. Dan, the research that it will enable will help them to improve the systems in all areas, because the data they are going to have on the go will help them do operations research, and the DG himself and others, the CEOs and the technical people who should be able to punch their phones and see what's going on, and they can make some changes. The second thing they can do is to integrate the health insurance data of all stakeholders in the health insurance ecosystem. And today, like we said earlier, there is this hyperfragmentation that is from the NHIA, the SSHIAs, the HMOs, the providers, the FMOH even, because of the health sector data, and even the citizens. So there is the development part. So what HIMIS would do is to integrate those operations. The third thing it will do is align this health insurance data with the DHIS. And that was the very first foundation of that engagement. And the Federal Ministry of Health and all of those that are managing the health information systems architecture in the country have been providing direction in this initiative. And then finally, the fourth thing is going to do is to enable digitization of data. It is important because everybody has actually spoken to this digitization, and Dr. Leahy, thank you very much for also reinforcing that what HIMIS would do is to be able to put on our palms the data that is not just in health insurance, but also in the wider health systems, to be able to see how health insurance contributes meaningfully to the improvement of the health systems. And just finally, let me just reiterate what I said earlier. One of the key things we must do is governance. So that governance in terms of strategic direction and policy with the various people in the or institutions in the ecosystem is very important for us to look for.
Thank you very much, Dr. Francis. I have a last question for you. I know that our time is fast spent. How do you think, and you have only 1 minute to answer this question, how do you think we can better organize technical assistance in health insurance space for the NHIA and for the state? There are a number of donor agencies here, but there are a number of states that are flooded with development partners and they are orphan states. How do we better organize this technical assistance?
Coordination. If we're able to coordinate ourselves and move everybody together within and along the same vision, this will happen. But if we do not do that, then we see ourselves being dragged by various stakeholders at all times and we lose focus.
Thank you very much. So on this note, I would like to thank our panelists and for the great contribution. In the last 1 hour thereabout, we have been trying to dissect how best different stakeholders can contribute to the goal highlighted by the DG of NHIA. So what is very clear now, going forward, we are paying attention to coverage, we are paying attention to equity, we are paying attention to quality, and we are paying attention to, can you remember the last one? Accountability. Show that somebody is falling. I did it on purpose anyway. So I would like to, and in the last 1 hour, we have been looking at it from different sectors, from the financing aspect, where would the additional money come from? What do we need to do differently? From the provider, what do we need to do to the provider to ensure that they are happy and they are able to contribute to this goal? From the issue of a data, which is very central, how do we generate data? But more importantly, how do we use data for decision making? How do we reduce the fragmentation in the generation and utilization of data and the quality of data as well? From the state health insurance scheme, which has helped us to contribute at least half of the coverage of health insurance, but that one too is a product of the national health insurance because it's national health insurance that actually started the decentralization policy. But of course, we are all working together in the ecosystem. And to the HMOs, they are doing a very, very great job. We have listened to them in terms of what we need to do differently. And we have listened to the civil society in terms of how we should be more intentional about engaging the civil society to be very, very clear about what is the advocacy agenda. And then Dr. Leahy also emphasized the need for digitization. We're in the 21st century. DG, they reiterated the need for us to have an hub where we can do a lot of transaction. So on this note, I would like to thank even the audience that asked questions and contributed and listening as well. And thank you very much. On this note, by the power conferred on me, I will disband this panel and hereby disband.
Thank you very much. And I think they deserve a very loud round of applause. They have been able to generate and stimulate us for better understanding. DG, you're welcome. Well, I'd also like to welcome in our midst, I know she left a few moments back, Sinu Korean, the Health Office Director of the USAID Nigeria. Please extend well wishes to her. But my brother is here, Dr. Sylvester Akonde of that office. Thank you very much, Dr. Akonde, for all that you do to allow things like this to happen, helping the local health system sustainability project to still thrive and stay alive. We thank you very much. At this moment, I'll just, DG, I'd like to call on the representative of the Nigerian Governors Forum to just speak to us for like 1 minute, 30 seconds. But considering that we need them as stakeholders, the governors, we'll extend it to 2 minutes. Thank you. 1 minute.
Good afternoon, everyone. Thank you for having me today. So I jotted down some notes, but I don't think I have anything technical to say. It's all been said here. Everyone in this room, I'm seeing faces that I've been familiar with in this space for years, and that shows commitment. On behalf of the Nigeria Governors Forum, all I have to say, especially to the state health insurance agencies, is that we're committed to support you in terms of your technical capacity, in terms of, enriching and enhancing the political will of your state principals. We do that every day. We preach to them that the best way to have an optimal health system in your state is through health insurance. That's how you get your funding circulating within the system. You don't even need to up your budget if you get it right. So I would like to tell you that our doors are open. We're committed to that. And then we're also willing to be the bridge that aligns you with the national level through the NHIA. Thank you so much to everyone that has contributed here today. Thank you for this opportunity.
Thank you too. We'll listen to Dr. Sylvester Akonde for 1 minute.
Yeah, sure. Thank you so much, Auntie Muji. All protocols duly observed. So at USAID, we're very proud of our partnerships with NHIA, the Nigeria UHC Forum, and of course the subnational entities. And in particular for how well this strategic engagement has turned out. I was excited to see the vision that has been clearly set forth for the NHIA, and particularly because it aligns with the Vision 2030 for health system strengthening of USAIDs. I don't know how many people have seen that. So it is premised on the achievement of 3 intermediate outcomes of equity, quality, and resource optimization. And that perfectly aligns with the 4 things that you've set forth in your vision. And that makes us very excited because it then gives us the impetus to further support the direction that has been set forth. But that's not all there is. There is often what is said that vision without action is just a dream, right? So it's good that we have this vision set forth. It is the actionable steps that we take afterwards that will lead to the achievement of the vision that has been set forth. And my request to the DJ would be just one. I think it's very important that we set up a technical advisory group that will drive the process of achieving this vision and take very actionable. Be assured that at USAID, there will be continuous support from us, and we stand shoulder to shoulder with you on this journey. At this point, thank you so much, everyone.
Yeah, thank you very much. And thinking that everybody must come on board just at the right time. We have here the head of the sector-wide approach for the Ministry of Health. Dr. Mutaka just walked in. You're welcome. Please, can we? Yes, you're still consulting. Well, he's here, so the sector is getting wider and wider, and you have more collaborators here. You want to say something? Sure. Sell your market.
Thank you very much. Not necessarily my market, but I wanted to convey the. Can I just stand? Or? Yes. Just wanted to also, convey the greetings of the Honorable Minister. He had wanted to be here today, but he's also doing his one-year achievements with the presidency. So his job security is on the line. So he had to unfortunately prioritize that. Otherwise, he would have absolutely been here. But I also wanted to add my voice in thanking everyone for this opportunity to engage. I think we are really at an inflection point, and this conversation is incredibly relevant. I think from where I sit, I think you mentioned the sector-wide approach. I think for us, it's really around improving governance, aligning efforts, amplifying impact on health outcomes, but also converging resources through the framing of one plan, one budget, one report, and one conversation. Within the context of one plan, I just wanted to highlight that our overarching agenda is crashing maternal mortality, but also expanding financial protection, so insurance. And I think that's why this conversation today, mobilizing and engaging stakeholders, is really at the heart of what we mean by one plan, one conversation, right? To get the perspectives and inputs from all of the various stakeholders here, but also aligning, of course, with the strategic blueprint, the blueprint of the NHIA, right? So everything from its quality agenda, its market shaping, improving enrollees. I think all of those themes are really at the heart also of the direction that the ministry is trying to go around governance, around improving population health outcomes, but also in a sustainable way, right? So I think that's kind of what is critical about this, as well as health security, which is a fourth pillar, but also medical industrialization, right? And an important piece of that, I think ultimately we don't have a health market if there is no mature, credible payer market, right? So I say all this just to tee up all of the important threads and themes, and just to highlight how important the conversation around health financing, but also sustainability, market shaping, and the policy reforms that will be required to get these enrollee numbers up and get the sorts of coverage that we're solving for. Because ultimately our health system is around, yes, responsiveness, outcomes, and also kind of quality. And just wanted to thank all of the stakeholders for the opportunity to at least be part of this discussion. Over. Thank you.
Thank you. Okay. The good thing about this meeting is that everyone who spoke broke down the technicalities for everybody to understand. So I can see some threats on my job as an anchor, but I'll take that in good faith. So sometimes I can have longer weekends that I'm witnessing. But seriously, I think that we all have gone on a learning curve and we need to consolidate on this starting from yesterday. So at this point, I'd like to bring in the Director General again, to give us the closing remarks and what he intends to do with the pool of resources here in this hall.
Thank you very much. I think my job is easier than that of the panel. When I walked in and I saw the people sitting here, very intimidating and powerful panel. And in my mind, I was like, if we have such people who care about the healthcare system in Nigeria, then I will sleep well knowing that these people will also bear the burden with me, and that with our collective efforts, things will get better. We have outlined quite an ambitious vision for the NHIA, but it's not ambition because we do not appreciate how difficult things will be or the context in which we work. But it's because we know that if we're ever going to do something that will take us away from what has been a protracted low coverage and poor financial protection, we have to really reach for the stars. We have to do something much more drastic than what we've done before. And looking at everybody that was on the panel and all the resources here, the question that kept on going on in my mind was, are we really greater or less than the sum of our parts? And as a result, what I would propose that we go for is to continue this collaboration, I think as articulated by Dr. Muntaka. How do we bring this together so that at the end of the day, it benefits the Nigerian, it benefits the enrollee? It means collaboration has to be much more. It means that we cannot have a zero-sum approach to this, where if a state health insurance agency is winning, it must be that the HMO is losing. If the provider is winning, it means there's something we haven't figured out. There's a hack somewhere. We have to not look at this as a zero-sum game by keeping our eyes focused on what is really important. To reiterate, the unit of our intervention is the enrollee. Is that person, making sure that person has financial access to good quality care. And that is really what this is all about. So first I'll say thank you to everyone that came here. Thank you for challenging us. Thank you for the feedback. Thank you for the ideas you have shared with us. We hope that as we go along, we will have such forums. And so I am committing the NHIA that at least quarterly, we should have a forum where we have an honest discussion and conversation on how well we are progressing towards realizing this vision. You will hear from us transparently in terms of what we are trying to do and initiate. And we also hope that we'll have candor. It serves nobody, it does no one any good if the first time you're hearing about something is from the media or randomly. So let's create that forum for conversations, for challenge, for advocacy, for brainstorming and collectively solving the problems that we have. On specifics, I think what was raised with regards to the shares, very well noted. The contribution has been immense, and we are working to continue to support the state health insurance schemes. We're all Nigerians, and I think we can work together to ensure that things move forward. On the issue of the app, Dr. Lekki, I think well noted. We have already started working on one, and hopefully we'll be able to get something out with also trying to revamp the website so that, yes, indeed, people don't need to keep coming to the enrollment centers. You should be able to enroll. And some of this is already being done in the States, but in the NHIA, that's something that we're also working on. Data points well made, and I think Dr. Francis addressed that. And I think it's important to understand how do we situate ourselves in the whole healthcare agenda. We know that what is really important is health outcomes. We know that it's important that the beneficiary actually has good access to that. But we also know that we're not the only ones working on these things. We work within a system. where we have to rely on our counterparts on the supply side to ensure that good quality healthcare is provided. And that's why they are here. We also know that we have to rely on the policy framework and the strategic vision that is set by the Federal Ministry of Health, as articulated by Dr. Muntaka. What role does insurance have? What is the approach we have to this? And it's really that. It's about making sure that people have that financial protection. So if we are being obsessed with enrollees, it's because this is an area that the mandate falls squarely on us. And this is the contribution we bring to the broader health ecosystem so that the demand side complements the supply side and results in improvement in health outcomes for the beneficiary. So I think it's important to situate this in the bigger picture. But unless we are laser focused on those numbers of enrollees, on people who have that coverage, I think the system will be lacking a critical factor to strengthen it. So I think with that, thank you everyone for coming. Really appreciate the time. And hopefully this will be the first of many more substantive engagements we'll have going forward. Thank you.
Thank you very much, Gigi. If you look on the screens now, are you ready? Can you bring that on? This conversation continues online. We also want to appreciate, yes, that's the email where you can send in your comments. And for those who are not able to bring forth their thoughts, this is the platform that has been put together quickly for here. It will improve, but it's for Q&E, making this conversation alive, Q&A rather, and making this conversation alive going forward from this hall. This was in the last 10 minutes. So please look through this, ensure that it's alive and well articulated to continue the conversation. So I think it's been worthwhile spending our Friday here instead of doing other things. I thank God for this forum because I've been trying to get Dr. Muntaka. I don't know where he's been. Yes, I've been like hunting for you, but thank God for today. Yes. Oh, okay. There'll be lunch at Ballroom 4. I think members of the NHIA would be able to direct us there. Well, on behalf of Nigeria UAC Forum, I'd like to also thank all that have made time to attend. We intend to continue with this, collaborating with other CSOs and non-state actors. It's important that from our end, we must continue to collaborate and get this job done. But what I want to hear from all of us before we leave, is this doable? Is it doable? I wanted us to bring the roof down. Please, I have my heart on my tongue, so let's know that today has been worthwhile. Is it doable? Is it actionable? Can we get there? Good luck. Bless you.